But there's no conflict on it, since we all know that AHA is also a researching body, side by side with the international liaison on the Committee on Resuscitation, ILCOR. But the good thing with our program is, so far, as far as I know, ang WIPAM pa lang ang naka-take off sa interim guidelines of 2022. So we are proud of that. So kung meron kayong makitang basic life support programs, pinaka-latest nila is 2020. Yun pa rin naman ang sinusunod, except nag-adjust lang sa COVID. Kaya we have these interim guidelines of 2022. So at the outset, the 2022 talks about COVID mainly. And the funny thing is, we are 2023, and the surges of COVID, hindi na siya katulad dati. Kung makita niyo, parang hindi na applicable. But for the sake of academics, kasi at the end of it all, tatanungin tayo anong program ang sinunod mo? So pag sinabi mong, I took the basic life support program following the American Heart Association under the interim guidelines of 2022. So ganun ang mga sagot, no? Particularly in the international scenario. Laging may pagbabasihan, no? Kasi we are practicing evidence-based medicine. So I'm Dr. Ted Esguera. I am an instructor for operational medicine. So medyo paus ako, nagturo lang ako ng trauma just yesterday sa Quezon Province. And preceding that, I was in the home court of your Ma'am Joy. I was somewhere in Gainsa, near Naga. I was teaching combat medicine. So my specialty is mainly operational medicine, meaning I'm a doctor in the field. Of course, nobody likes the field because, first and foremost, except that it has lots of adventure. But it requires two things. One is you have to have logistics going in the field because you don't have hospital. So parang gagawa ako ng hospital in the field. Kung parang gagawa ako ng ICU. Pangalawa, siyempre, kailangan medyo may kalakasan ka doon kasi you will carry your own equipment. But my way of teaching you is in hospital scenario. Now, I don't like to discuss BLS without telling you its relevance in the scary times. When I say scary times, ang panahon ngayon medyo nakakatakot dahil according to the statistics na mabasa niyo dito, sudden cardiac arrest is the leading cause of death even dito sa Pilipinas. No, ang Pilipino parang Amerikano, British na rin. No? Almost all over the world, number one siya. Hindi kayang tapatan ang statistics sa mga taong namamatay sa giyera. Sa Gaza, sa Ukraine, wherever, Azerbaijan. Isama ko pa pati conflict sa Aleppo and sa Marawi. So, that's the reality. And another bad news, the people who are affected, I mean the portion of the population, the bracket in the population, the affected personages are getting younger. Pabata ng pabata ang tinatamaan ng cardiac arrest. And another unfortunate thing in this country, hindi pa nabuo ang 911, ginagawa pa. So hindi reliable pag-ano si 911. Number two, we don't have an EMS law. Kung makita nyo rito, EMS response. Dito sa Pilipinas, walang EMS law. Maraming ambulance, maraming EMT, walang EMS law. So there are lots of gaps and setbacks when it comes to addressing pre-hospital cases, particularly cardiac arrest. So lahat nito nakikinig sa akin, ilan tayo dito? 30 plus. Kandidato tayo ngayon. Before I'll move forward, when I talk about cardiac arrest, there are modifiable and non-modifiable traits or factors. Pag sinabing non-modifiable, sino yung mga makakakuha ng cardiac arrest? So mas mataas among sa kalalakihan, male. So hindi ma-modify kasi male eh. Pangalawa, age. We cannot modify age. Habang tumatanda ka, syempre nag-stiffen yung blood vessel mo. Kandidato. Next is heredity. Pag nasa pamilya mo, most likely makukuha mo siya. So wala kang choice. Pero doon tayo maglalaro sa modifiable. Ano yung modifiable? Number 1, hypertension. Pag meron kang alta pressure, bababain natin. Kasi wala ibang choice. Ano pang pangalawa? Hyperglycemia, yung diabetes, kasi contributory siya. So, i-control natin ang sugar. Ano pang sunod? Hypercholesterolemia. O, bigyan natin ng statins, fibrates, depende kung anong. So, kailangan lang dito is constant monitoring. Ano pa? Smoking. O yan, sa mga naninigarilyo nakikinig sa akin. So, isa siya sa mga factors na magkaroon ka ng cardiac arrest. Ano pa? Obesity. O di, slowly, you trim down, exercise ka. Ano pa? Sedentary lifestyle. O again, bagay ako, tamad na ako mag-exercise din. Pero kahit paano, takbo-takbo ako nung nasa Naga ako. Nag-drill kami kasama yung police, no? Kasi, kunwari, merong shooting, mga ganon. Ano pa? Stress. Mahirap talaga. I don't have any advice because my life is also stressful. Although, nagre-relax lang ako, naglalaro ako ng chess, kinakaaway ko ang AI. So, medyo hindi naman ako stress pag natatalo ako ng AI. Pero minsan nananalo ako. So these are the modifiable things na kailangan i-correct natin. Kasi whether we like it or not, sabi ng World Health Organization, global scare na siya. Now, here, it is during those critical minutes na kailangan meron tayong intervention. Yung tinatawag nating cardiopulmonary or yung CCR, cardiocerebral resuscitation. Para, ang simple lang, when we pump the heart, during pumping and recoil, kusa pumapasok ang hangin. So other than the blood running in, running all over the body, particularly to the brain, kasama na rin yung 21%. Saan galing? Bawat recoil mo, papasok yung hangin sa baga. So, 21 yon. Hindi tayo nagma-mouth to mouth. Unless, kapag nasa hospital ka, may non-rebreather non-rebreather mask, or merong bag valve mask attached to the oxygen at 15 liters per minute, yun, mataas yun. Maabot tayo ng mga 90% of oxygen. So there's an increased chance of survival. Now, for today's objectives, we will describe what's BLS, and we will look at the chain of survival kasi the chain of survival is our storyline. Ika nga, kung ikaw ay artista sa isang pelikula, ano ang script mo? Ano yung storyline ng pelikula? The chain of survival is the storyline in sequence. So there are two storylines, ang in-hospital saka out-of-hospital cardiac arrest. Pero ang ituturo ko, in-hospital, although dadalhin ko rin kayo sa out-of-hospital kasi maka-alas 5 ng hapon, pauwi kayo sa inyo, biglang may bumulagta sa kapitbahay nyo, siyempre, kilala kayo, doctor or nurse. Kasi nung pumasa kayo sa board exam, yung mga pangalan ninyo, pinaglalagay ng kamag-anak ninyo, tarpaulin, billboard pa, no? So, ang buong barangay, kilala ka. E ngayon, pag may mangyari sa barangay mo, kahit off-duty ka, mapipilitan kang pumunta kasi there is already an expectation. Because your name, after your name, Juan de la Cruz, RM or MD, nakalagay doon. So, we don't have choice. There's already an expectation. Now, interim guidelines of 2022 talks about COVID protocol. I will not discuss the whole part of it kasi napaka-detalye. But if you ask for the slides, nandun nilagay ko yung mga patakaran sa interim guidelines. No? Hindi ko siya himay-himayin. Kasi una, ginawa na natin during the surges of COVID simula noong 2020, ginawa na natin siya. Eh ngayon, wala na eh. Hindi na tayo level 4, level 3, halos wala na. Nagmamask pa rin tayo pero wala na tayong mga shield. Hindi na tayo nakabalot lahat na parang astronaut. And then, sa objectives natin is we have to visit the stations. Compression station, rescue breathing, foreign body airway obstruction, AED operation, and then the naloxone. Ito yung hindi nyo alam. No? Pero to comply with the 2020 standards, kahit hindi uso ang naloxone sa Pilipinas dahil bihira ka lang makakita na opioid toxicity kasi hindi naman natin kaya yung mga opioid, no? Hanggang shabu lang tayo. Shabu is a poor man's amphetamine yun. And then for those who will be taking ACLS, so the BLS primary as a bridge to ACLS secondary. Basic life support is an intervention to both an urgent treatment or to a agonal scenario in a cardiorespiratory incident. So intervention siya, like for example, if you meet an unconscious individual, adult, child, or infant man yan, na walang pulso or with an agonal breathing, and then you intervene. It's also an intervention to an airway obstruction, kumain ng kasi Pasko ngayon, kumain ng buong meat ng turkey, bumara, ayan. So, foreign body airway obstruction. And of course, kapag meron tayong opioid poisoning, and how do we give naloxone? Kasi sa Pilipinas, ang naloxone natin ay intravenously given. So dito makikita nyo meron palang nasal spray. So it is performed by trained personnel. So who are the trained personnel? Kayo na after taking the course. So you will receive certification to signify that you are basic life support provider. Sa American Heart Association, meron silang tatlong pathway. Pag pumasa ka sa BLS, kahit sa ACLS or sa Pediatric Advanced Life Support, tatlo yung pathway. Una, pag naipasa mo, sa certificate, provider ka. Parang P. Sa instructor's manual, nilalagyan ng P, provider ka. Ibig sabihin, pumasa ka sa didactics at sa practical, so provider ka ngayon. Okay? Meron namang mga tao sa kamalasan hindi pumasa. So wala kang certificate, pero nakamarka doon, parang to repeat, ulitin mo. Then, meron ding nilalagay sa instructor's manual. Halimbawa, ikaw nag-take ka, tapos magaling ka, nakitaan kang magaling ka. So napasa mo, pero doon sa instructor's manual, sa instructor's assessment notes, nakalagay doon IP, instructor's potential. Usually, sa ibang bansa or sa yung talagang may full-blown facility, sinusulatan ka. No? Hahanapan ka ng sponsor para i-train ka as instructor for both ACLS, BLS, or PALS, and NRP, Neonatal Resuscitation Program. Parang ako, nasulatan ako dati. So may nag-sponsor sa akin. Ang bayad, grabe-grabe kamahal. Binayaran talaga bawat isang tao. Mabot ka ilan kaming tinuruan? Tatlo lang. Tatlo kami. Instructor's potential. gumastos for so many years ago ng almost 200,000 para sa amin. Kasi yung mag-a-assess sa amin para maging instructor kami ay galing pa sa California. Kaya ganun ang nangyari. Now, the scope is, of course, the 2020 protocol, and I will not read the whole litany of it. Then compression mechanics, AED operation, BLS in COVID situation, foreign body airway obstruction management, rescue breathing, tapos naloxone induction. Most of them, magkakaroon tayo ng laboratory online, virtual lang. So, halimbawa, mag-compress ako, pakitaan ko kayo ng mga iba-ibang style na compression. No? And then, paano ang gagawin sa airway obstruction? So, I will do it virtually. No? So, meron akong dummy, papakita ko paano natin gagawin. Kasi hindi tayo face-to-face. Para masatisfy natin yung batteries of yung laboratory or the battery of practical demonstration. Basic life support is, of course, mandatory requirement ng ACLS, ng Pediatric Advanced Life Support at saka Neonatal Resuscitation Program. So nakalagay dito. Hindi siya mandatory pero kailangan marunong ka sa basic life support, sa advanced trauma life support, sa pre-hospital trauma saka sa ITLS. Pero ang ATLS is only for doctors. Okay? Hindi pwede kumuha ang non-doctors. Hindi rin siya requirement pero dapat marunong ka sa MOET, Management of Obstetric Emergency and Trauma, and then sa ADLS, Advanced Disaster Life Support, Advanced Medical Life Support, Wilderness Advanced Life Support, saka sa sa Austere Environment Life Support. Actually, sa Austere Environment Life Support, hindi siya mandatory, but kasama siya doon. Merong basic life support ang Austere Environment Life Support, Acls. Now, the package of BLS is 1, understanding chain of survival, then compression of adult, child, infant, foreign body airway obstruction management, tapos rescue breathing, AED operation, and naloxone induction. So ladies and gentlemen, welcome to the chain of survival. So dito lang tayo, titingin muna sa itaas kasi ito kayo. So there are now 6 chain links. 6 links. 6 na links. Hindi katulad dati 5 lang. Dinagdagan ng recovery. Ang emphasis on the recovery kasi nakita kasi nagkakaproblema sa recovery. What do you mean may nakakaproblema sa recovery? In the days of, not really old, in the recent past, nagawa lahat ng hospital, ng ambulance, ng hospital, nagawa to. Okay? Nagawa nila. Ito lahat. Tingnan yung cursor ko, nagawa nila. Pag uwi sa bahay ng pasyente, napabayaan or sa society. No? Kasi halimbawa, stroke patient, not victim, stroke patient. Inuwi sa bahay or nasa society, tapos yung lipunan niya, walang pathway for stroke, so hirap na hirap. No? Dapat, nasa batas natin, merong ramp for wheelchair, mga ganun. No? So doon pa lang sa lipunan, wala na. Palyado na tayo. Mahina ang Pilipinas. So, nag-e-effort yung mama, nagka-stroke. So, mag-re-bleed ulit siya, assuming. Ganun. Or pag-uwi sa bahay, hindi natutukan yung gamot kasi yung PSG or primary support group mahina. Yung family niya, wala lang. Parang sa atin, parang pinabayaan lang yung pasyente. So, ngayon, ine-emphasize na ang recovery ay dapat paigtingin natin. So, we start with the first link, early recognition and prevention. Kung sa disaster management yan, ang tawag dyan ay risk reduction. Kaya kanina, yung sabi ko sa inyo, high risk, the number one killer of humanity in the whole world is cardiovascular. Sa buong mundo yan. Mas nakakatakot yan kaysa kay COVID. Alam ko, natakot kayo sa COVID. Katulad ko, first batch akong nagka-COVID, muntik din ako namatay. Pero mas nakakatakot ang cardiovascular. So nataranta sa COVID pero hindi nataranta sa cardiovascular. Sa COVID, pag na-COVID ka, hindi ka naman mamamatay diretso, no? Ubo-ubo ka bago ka maging abo. Pero may time pa. Hindi ka naman may ubo, patay ka kaagad. Pwede ka pa mag-TikTok. Pero pag may cardiovascular incident, pag nag-massive MI ka or massive stroke, diretso ka na. No goodbye. No closure. Yan. So, minsan yung way natin on to titingin sa sitwasyon, particularly kapag medyo bago sa paningin natin like ang COVID, natakot tayo. Pero nobody minds cardiovascular incident. Kaya mga tao ngayon, ang dami pa rin nag-yoyosi. Yan ang patakaran kung bakit nasabi natin na halos ang tao walang pakialam. Pag kumain ng taba, grabe. Sugar ang taas. The sugar is the main killer. Actually, it's not the fats. Our body is needing fats. Ang brain ko, kailangan niya ng cholesterol. Sakto lang yung cholesterol. But walang nakakita na ang isang killer is the sugar. Yung mga palakain ng matatamis dyan. Okay? So dito sa prevention and recognition, naglaan tayo. What if there is an accident? Then there is the activation of emergency response. Then high quality CPR. Pag sinabing high quality CPR, according to 2020 guidelines, up to 2022 interim guidelines, push hard, push fast. The rate is 100 to 120 per minute with adequate recoil. Okay? Hindi na ini-emphasize yung 2 inches to 2.5. No? Wala. Basta push hard, push fast. Okay. Number 2 doon is minimize interruption. Number 3 is avoid hyperventilation. Number 4 is you have to shift the compressor every 2 minutes. And down the line. So itong high quality CPR, ito yung pinaka cornerstone, no? Cornerstone of survival. Then defibrillation. Ngayon sa Pilipinas, in-encourage ng National Philippine Red Cross na magkaroon ng public access defibrillator. So they are trying to encourage na yung defibrillator ay nakikita sa paligid. Hindi pa rin. Although sa airport meron, no? Sa ibang mga LGU meron na. Davao, ayan meron. Hindi katulad pag pumunta ka sa Japan, lahat ng establishment meron, AE. Then after defibrillation, the post-ACLS care or post-cardiac arrest care. Ito yung depende gaano kakatagal sa CCU, cardio, coronary care unit pala CCU. Then recovery. So yan lang yung tapos balik ulit sa simula kapag may kaso. Dito sa ibaba is the out of hospital. Makikita nyo, kasi wala naman tayong alam, bumagsak na yung tao. So activation of emergency response, high quality CPR, defibrillation doon sa site. Then, ang nadagdag is yung ambulance na merong ACLS capability. Ibig sabihin, ambulansya na ACLS ang kanyang loading. Then to the hospital, sa CCU, sa coronary care unit, and then sa recovery. So, ganyan lang ang assembly. Ang pagkakaiba lang ay sa child chain of survival. Sa chain of survival sa in-hospital, pareho lang din. Sa out of hospital, dito kayo masyak. Bakit? Kasi bihira tayo gumagamit ng defibrillation sa child out of hospital. Ang nadagdag lang sa child ay prevention. Magtaka kayo, bakit sa adult walang prevention? Sa child, emphasize ang prevention. I cannot explain it on the context sa medical. Although, nilagay naman nila. I'll explain it on the context of social anthropology. Ang bata, tayong mga adults, ang trabaho natin is to create the world for the children. Ganun lang naman yun eh. Simple lang. Nandito tayo ngayon para sa next generation. Lahat ng pinagtatrabuhan natin para mabiyayaan yung next generation. Itong mga generation ngayon, minsan, hindi nila ma-realize, akala nila napaka-advance nila. Na-enjoy nila yung advancement nila because there were people like us or like me na matanda na na-create yun. Ang mali lang na na-create ko sa henerasyon ngayon ay naka-create ako ng very lax na generation. Hindi katulad ng panahon ko, bugbugan yung physical namin, no? Ngayon, bawal na. Magturo nga lang ako sa sundalo. Hindi ko pwedeng i-bakbakan yung mga new officers kasi daw matutulfo ako. Oh. Wala na, medyo, sorry with the word, inday-inday yung generation ngayon. Natatakot ako pag girahin na tayo ng China. Wala akong warriors kasi napaka-weak ng physical ng generation ngayon. Hindi sila sanay sa hirap. I will blame myself. I blame myself. I become lax on that. No? Hindi katulad ako, na dumaan ako sa, napukpok talaga ako, nabugbog talaga ako. And I'm proud, no? Ngayon, hindi ka na pwede magsinturon ng bata. Ako, nasinturon ako ng tatay ko. But it made me who I am. Yung disiplina ko, nandoon. Kahit ang tatay ko naninigarilyo, sinisig ko, sinasampal niya ako para hindi daw ako manigarilyo, pero siya naninigarilyo. Kaya hindi ako naninigarilyo. Kasi lagi kong naisip na sampalin ako ng tatay ko, kahit patay na yung tatay ko. Ganon yun. Kasi napukpok ako sa time ko. Ayan. So, but dito, balik ako dito sa chain of survival, itong prevention, it is because in the aspect of anthropology, ang trabaho ng adult is to prepare the children. So, mas mahirap tingnan ang isang bata na nahihirapan kaysa sa isang adult na nahihirapan. Ipagtabi ko sila. Psychologically, ganun yung impact. Kaya ang mundo, ang kanyang vantage point must be focused on for the benefit of the younger generation. Kaya dito sa out of hospital, meron tayong prevention. Yan. Okay? And the rundown of basic life support is after checking if the scene is safe, kailangan mag-assess ng responsiveness. Tapos, kunwari, unresponsive siya, activate emergency response, or pag nasa hospital, activate code blue team. Ngayon, dito ako muna hinto. I don't know if you have a code blue team. During my series of lecture, particularly pag mag-join kayo ng ACLS mamaya, I'll be using code blue. Kasi yun ang kinasanayan ko. So pag sinabi kong code blue, that's a cardiorespiratory arrest incident inside the hospital. So para hindi tayo mawala sa konteksto, pag gumamit ako ng code blue. Yan. Maintindihan lang ha. And then, cover the patient with mask or with a non-rebreather mask or a surgical mask. Pag sa out of hospital, surgical mask. Kasi yung principle noon, pag nag-CPR ako, para hindi lilipad yung aerosol, matatrap sa mask. Pero pag sa in-hospital, pag wala pang bag valve mask, kinokobera natin ng non-rebreather mask. I-demo ko mamaya. Before starting compression. And then, compression. So if you look at this slide here, dito mo makikita what happens to the brain. So dito, sa konteksto ng isang European, ay 10 minutes. Pero nasa Pilipinas tayo, hindi tayo mag-European. 8 minutes lang tayo. Pilipinas kasi tropical. Mas mabilis mag-waste ang tissue dito kaysa sa lugar na malamig. So 0 to 1 minute, cardiac irritability. Philippine context ha. 0 to 3 minutes, brain damage not likely. 3 to 5 minutes, brain damage possible. 5 to 8 minutes, brain damage very likely. So hanggang 8 minutes. Ibig sabihin, dapat ang isang tao may cardiac arrest, within 8 minutes dapat meron tayong ginawa. Kasi more than that, pahirapan. Now, if you look at this slide, pinakataas na na picture ay isang tao merong fibrillation, walang ginawa, no intervention, and then na flatline. So patay. Dito naman sa pangalawang picture, merong fibrillation, cardiac arrest, flatline, pero nag-shock. So pag-apply ng shock, meron daw percentage survival. So, sabi dito, 2%. Dito naman, sa pangatlo, may CPR, late dumating si defibrillation, may chances of survival. Depende sa age category, 8 to 16% yan. 8 to 16%. Depende sa age category. Yan. Itong pang-apat na picture, merong defibrillator kaagad, umakyat ng 32%. Dito sa ibaba, umakyat ng kompletong package, umakyat ng 70+%. Kalimutan ko, but 70 plus? Depende sa age category pa rin. Ibig sabihin, one of the greatest inventions of man, the defibrillator, is very useful para tumaas ang margin of survival ng tao with a cardiac arrest, lalo na kapag ang cardiac arrest niya ay shockable rhythm ang presentation. So, yan. Welcome to the interim guidelines of 2022. So, yung 2020 na mechanics, pinukpok lang si COVID, ang tawag is the interim guideline of 2020. So, ano ba ang interim guideline 2020? Ang emphasis lang is how to avoid or lessen the likelihood of transmission. So, anong ibig sabihin yan? Una, kailangan naka-PPE tayo. Okay, ayoko mag-react kayo kaagad kasi hindi na kayo nag-PPE ng level 4, level 3. Tandaan ninyo, ang interim guidelines of 2022, ginawa yan 2020-2021. Nirelease 2022. Okay, so para alam niyo lang, ganun siya. Noong 2020, nag-release ng 2020, ang AHA, ginawa 2018. Kaya pagbasahin niyo ang 2020, walang ni-mention ng COVID kahit isang beses. Ang COVID, nag-start siya 2019, late 2019. Kaya pag sinabing nag-adjust siya, gumawa siya ng interim. What do you mean by interim? Yung interim, ito yung isa English, it's like, it talks about time, the intervening time. Noong 2020, walang COVID, bago na, wala na akong magawa. Na-release na yung libro na 2020. May COVID. Hinabol nila. So, paano nila hinabol? Naglagay sila ng additional. Pero wala na. Meron na akong hard copy na nakuha. Hinabol lang via online. Since wala namang pagbabago sa compression or what, dinagdagan lang ng COVID protocol. On the moment na kailangan may intervention ka, kaya tinawag na interim. Interim meaning the intervening time. Okay? So, noong 2022, kasagsagan pa rin si COVID, although may mga vaccine na, ni-release nila. Bakit 2022? Kasi nakita nila sa 2020, 2021, yung COVID. Nag-release sa 2022, kaya tinawag siyang interim guideline of 2022. Ngayon, nasa 2023 tayo, magre-react kayo, ay hindi na siya tugma, wala nang COVID surges. Yes, agree. But for the sake of academics, gamitin natin ang interim guidelines of 2022 para makakomply lang tayo. Kasi whether we like it or not, yan na yung mundo na kinikilusan natin. So ano yung interim guideline of 2022? Number 1, bago mag-attend to a case, kailangan nakadon ng PPE at levels 3, level 4. Ganyan lang. Okay? Pangalawa, limit personnel. Ano ibig sabihin ng limit personnel? Dati, pag merong basic life support, nag-intervene ka sa pasyente na nagka-cardiac arrest, Ang pinaka-ideal mo, basic ha, basic life support, pinaka-ideal mo is 4. Ano yung 4? Airway, magbabag, compressor, pangalawa, electrical therapy yung nagdi-defib, kapalit ng compressor, palitan. And then team leader. Alam mo saan si team leader? Nasa paanan na ano ng pasyente. Para nakikita niyo yung team niya pati pasyente. Ngayon hindi na. Ang interim guidelines minimize siya. 3 na lang siya. Nasaan na si team leader? Si team leader ay pwedeng si airway or pwedeng si electrical therapist na magiging compressor. Ang tawag sa kanya sa Philippine context, Jaworski. Bakit Jaworski? Playing coach. Diba si Jaworski sa basketball, hindi naman umaling mag-basketball. Coach siya pero naglalaro. So ito, ang team leader mo is the player. Nag-electrical therapist ka or magiging compressor ka every 2 minutes. Palitan. Bakit magpalitan? Kasi yun yung 2020 guidelines ni American Heart Association. Then another thing, ito yung hindi nagagawa kasi karamihang hospital walang ganito. Consider using tamper or mechanical CPR. Yung nilalagay sa dibdib na nagsisipr. No? So, oxygen powered yun. Vampire yun ng oxygen. Mabilis makaubos ng tangke. Hindi naman lahat. Siguro sa inyo, wala kayong tamper. Makikita niyo yung machine na siya nagbibigay CPR para hindi na tao. So, medyo hindi ko masyadong i-advocate yan kasi 98% sa Pilipinas hindi gumagamit ng tamper. And then, communicate COVID status to new provider. Then, prioritize oxygenation and ventilation strategies. Ito, ide-demo ko lang yan mamaya. Pag nag-demo na ako, bakit merong additional delay? May delay Dati kasi, di ba, pagbagsak ng tao, unahin si compression para walang delay. Ngayon, medyo unahin si compression pero hindi ka makakompress hanggat hindi pinapakilaman yung airway. I will do a demo on that. So dito sa slides ko, down the line, yan po yung gagawin. Hindi ko pwedeng i-explain lahat kasi itong iba ay ACLS na. Okay. So a little of ACLS. Dati inuuna ang IV fluid. Ngayon sabay or pwedeng mauna konti ang airway. No? So dati IV fluid tapos airway. Advanced airway intubation. Ngayon hindi. Kung pwedeng pagsabayin mo na. Bakit? Para mag-close circuit ako na hindi lumilipad ang mga aerosol. Saglit na bumalik. So ito yung interim guideline. I will not read so much on this. Ayan, mahaba. I will leave it to you. Kasi karamihan dito, ano na rin ACLS. Okay. Ito, ang updated April 2020, yung kanyang algorithm. Pero, under interim guidelines of 2022, kasi meron ng down PPE limit personnel. Ito ang pinakabagong algorithm ng basic life support in the aspect of performing compression and doing AED. I mean, utilizing AED. Ngayon, meron akong i-correct muna bago ako mag-umusad. Nagkakamali karamihan sa atin. Bakit? Dahil ang minensyon ng libro ay AED ng AED. Ang mga hospital, nagre-request din ng AED. Mali po. Huwag po kayo mag-request ng AED. Kasi, ang AED ay pang-layman. Pag gusto nyo bumili ng gamit, manual defibrillator with automation, with AED override lang, or vice versa. AED with manual defib override. So, yan ang bago ngayon, uso ngayon. Okay? So, hindi kayo pwedeng bumili ng AED kasi ang AED ay pang-layman. Ang bilhin nyo manual na merong AED interface. Sorry alam ko magagalit kayo sa akin. Dahil hindi natin naintindihan, nilagay sa requisition AED. Nurse, doktor po tayo. Nurse saka doktor. Hindi po kailangan nito ang AED. Kasi marurunong tayo. We are professionals. Huwag kayong mag-request ng AED per se. Bili kayo ng gamit, manual defibrillator, whether it's a Zoll, X series, M series, or a Life Pack 20, or any, or a Mindray, yan, yung mga bago. At yun ang na kailangan manual. Kasi bakit manual? Kasi syempre, hindi lang naman arrest yung tinutugunan natin. Mamaya pag ng ACLS, tutugon din ng tachyarrhythmia, wherein we will use cardioversion. Ang AED ay walang cardioversion. Tandaan yan. Okay? Kaya out si AED sa atin. Ang i-request na natin, AED with interface manual or a manual with interface AED, vice versa. So dito tayo ngayon sa slide na to. So itong slide na to, ay nagpedya ako. Adult. In-hospital muna ako. Bago mag-address sa pasyente, don't PPE, limit personnel. Tapos check for responsiveness of the patient. No? Kung sa hospital, activate emergency, activate code blue. Okay? Then, dahil ano tayo, pag activate code blue, check for pulse and check for breathing. Assuming meron kayo nakitang normal breathing with pulse, observe bakit na unconscious ang pasyente. Pag nakita natin no with pulse but agonal breathing, ang gagawin natin, mag-bag mask device tayo, bag valve mask, tuturuan ko kayo kasi hanggang ngayon maraming nagkakamali paggamit ng bag valve mask. So device with filter and tight seal. Ano yung filter? Ang bagong bag valve mask ngayon ay merong HEPA filter sa exhaust para ang expiration ng pasyente, kunwari may COVID, ay matatrap sa HEPA filter. So yung bag valve mask mo or yung ambu bag, yung bago po, dapat may HEPA filter box yun. Maliit lang. So napapalitan yun. Okay, yun yung ideal. Tapos, meron kang pulse pero walang saktong breathing, agonal breathing. You give one bag every 5 to 6 seconds. Okay? Tapos, while doing that, activate mo yung emergency response para mapuntahan, malay mo para ma-perform ang advanced life support if needed be. Then, in case nagkataon na ang patient goes into cardiac arrest, then baba tayo dito. Start CPR. Pero bago mag-start ng CPR, huwag ka muna mag-compress. Meron tayong delay 3. Okay. Makinig sa akin. Makinig ha. Saan ang delay? Yung delay, number 1 delay is pag nasa higaan, ibababa mo pa yung higaan. Diba? Sa ospital. Oh. Ibababa. O, segundo din yon. Sabihin natin, pagbaba ng, kumain ka lang 2 seconds, may 2 seconds delay ka. Number 2 delay, maglalagay ka ng cardiac board. Oh. So pag naglagay ka ng cardiac board, kailangan kumain ka ngayon ng 5 seconds. Oh. Or 6 seconds, sabihin natin. So may 8 seconds delay ka na. Okay? Kung kaya 6 seconds. Usually, pag nag-cardiac board, lalo na mga cardiac board natin, nagawa lang sa plywood, hindi katulad sa ibang hospital, talagang set up na, tapos yung higaan nila may automatic na bababa yung pagpindot mo for CPR. Eh kung nasa probinsya tayo, mano-mano, kakain ka na mas maraming siguro. The third delay, people, makinig, huwag mag-compress hanggat walang nakasalang na bag valve mask or non-rebreather mask. Kasi yan yung interim guideline of 2022. May nakasalang sa mukha bago mag-start mag-compression. Okay? So CPR, pam, 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 30. 30, bag ka dalawa. 1, 2. Huwag alisin ang bag. Hindi mo pwedeng buhatin kasi yan yung pangtakip natin para hindi lilipad sa aerosol. Pag nag-defibrillate, meron defibrillation. Pag nag-defibrillate ka, huwag alisin si mask kasi hindi ka naman makukuryente dahil rubberized or plastic yan. So, hindi siya conductor. Kaya, wala. Doon lang siya. Ang nakapatay lang oxygen. Okay, patay lang si oxygen. Kasi siyempre, ang defibrillator, kuryente yan. Kapag hindi yan, kapag hindi yan, pag hindi maganda, I mean, basa, nag-spark ang kuryente, sasabog tayo lahat sa ER. Okay, sasabog lahat. Kailangan, sakto, marunong maggamit ng bag valve mask. Ituturo ko mamaya kasi maraming nagkakamali sa bag valve mask. Okay? So, dito sa ibaba, hindi hindi nag-move ang slide ko or nag-move.
Hindi po ata, Dok, nag-move po.
Anong nakalitaw sa inyo?
Ito, sir, ay ito po, Dok. Reduce provider exposure, yung may doon PPE.
Nag-move sa akin. Okay, tanggalin ko. Share. Kita niyo na.
Yes po, Dok.
Okay, good. So, dito, balik ulit ako para sa mga hindi nakasunod. Don't PPE. No? Ibig sabihin, kung susundin ko yung interim guideline, PPE ako, level 3, level 4. Although, hindi nyo na ginagawa yan ngayon. Naka 95 na lang kayo. Pero for the sake ng interim guidelines, sige, sundin natin. So, don't PPE, limit personnel. Then, check for responsiveness. Pag wala, the patient is not responsive, nasa loob ng ospital, activate code blue. Ayan. Okay? So, ulitin ko, para sa mga hindi nasanay ng code blue, ang code blue is yan yung ina-activate kapag merong cardiac arrest or cardiorespiratory arrest. During the activation code blue, check for pulse. So habang nag-check ng pulse, tinitingnan kung merong breathing. Kung ang pasyente may breathing, may pulse, observe. Kung ang pasyente mayroong pulse, taki, kunwari taki yung pulse, at may agonal breathing, yung langap-langap siya, intervene using bag valve mask. Ano ibig sabihin? Naka-ambubag ka, tight seal, i-demo ko, paano gawin? Tapos magbigay ng air, magbag, one squeeze every 5 to 6 seconds. So counting yan, 1,000, 2,000, 3,000, 4,000, 5,000, pwedeng 6,000. Squeeze, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. Squeeze, gano'n. And then, along the way, kasi pag agonal breathing yan, tumawag ka na ng help. Okay. What if the patient has no pulse, no breathing? So dito tayo sa algorithm. Ito, nakita mo yung demarcation. Itong demarcation na to, ito yung magkakaroon tayo ng delay. Okay, ano yung delay? Tatlo yung delay. Number 1, kung naka-bed, naka-high backrest, ibabagsak natin yung bed. Delay yun. Ilang segundo yun. 2 to 3 seconds delay yun. Depende sa type of bed. Okay? Number 2, Insert cardiac board, another delay yun. Kakain tayo ng 6 to 10 seconds. No? Kung may tao na, 3 tao yon, 2 to 3 person. Para bubuhat sa pasyente, bubuhat siya, insert yung cardiac board. Okay. The third delay is hindi ka pa mag-compress. May cardiac board, kailangan nakalagay, nakasalpak ang mask. Pwedeng bag valve mask or pwedeng non-rebreather mask. Okay? So, ganon ang delay. Kaya hindi na ginagamit ang word avoid interruption. Ang nakalagay sa interim guidelines, minimize interruption. Kasi mayroon talagang interruption. So dito, CPR ako, 30:2. 1, 2, 3, 28, 29, 30. Bag dalawa. 1 and 2. Compress ulit. Pagdating ni defibrillator, shockable rhythm, compress ka. Pam, 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 pam. 30. Biglang, pagdating ni defibrillator, susundin lang natin. Kasi ganito yan ha. Tandaan nito. Habang nagko-compress ako, so kakain ako ng, 30:2. Tapos bag 2. Compress. Pagdating ni defibrillator, hindi hinto ang compression. Tuloy-tuloy lang siya. Nilagay lang yung patch. Sisirain yung damit para malagay yung patch. Pag nalagay yung patch, magsasalita ng defibrillator. Yung pagsalita ng defibrillator, hindi natin yung sinusundan. Kasi ang defibrillator, mag-start sa simula. Unit, okay. Apply patch. Pero naka-CPR ka na. So, apply mo yung patch. Check responsiveness. Tapos na yung check responsiveness mo. Tuloy-tuloy ka lang CPR. Tapos 30. Tapos bigay dalawa. Start compression. Pag start compression, susundin mo na yon. Meron siyang metronome. Ang metronome niya yung pwede pip, 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 pip. Yun ang sinusunod natin. No? So, ang defibrillator, yung AED, may dalawa siyang voice prompt sa Pilipinas in English. Tapos, visuals. Ibig sabihin, ano yung nakikita mo doon na gagawin? So, yan. Yung cadence ng pip, 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 yun ang sinusunod mo, hindi mo masunod yon. Bakit? Kasi 2 minutes tuloy-tuloy yun. Pero ikaw nag-30:2. Hihinto ka pag 30. 30! Buga dalawa. Pero ang AED, tuloy-tuloy lang siya. Pip, 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 tapos tuloy-tuloy ka. 30. After 2 minutes, sisigaw si AED, analyzing. Bibitaw ka ngayon. Walang kamay sa tao sa arresting patient. Si Bagbal Mask, naka-standby, patay ang oxygen, 0. From 15 liters, patay 0. Okay? Tapos, kung pagpatay, pwede mong ibuga sa kanya dalawa. 1 and 2 para mawala yung oxygen doon. Kasi high tension yun. So, hawak lang, dyan lang, para hindi lumipad ang aerosol. Bakit? Pag sumigaw siya, shock advice, time clear. Sisigaw ngayon yung tao. 1, I'm clear, yung electrical therapist. 2, you're clear, titingin sa airway. Ang tinitingin si airway, pati yung oxygen. Kailangan naka-0, nakita ni electrical therapist. Tapos si airway, sisigaw siya, titingin din siya sa oxygen, 0. Bago siya sisigaw na clear. Ulitin ko, 1, I'm clear, titingin sa airway. 2, you're clear, clear. Tapos titingin all around the patient. 3, everybody's clear, clear. Tapos pindot yung lightning doon sa defibrillator. Nagbigay ng shock. Pag nagbigay ng shock, yung lungs magko-compress yun. Pag nag-compress yun, walang mask, lilipad ang aerosol. Kaya, ang bag-valve mask ay nakalagay lang sa mouth and nose ng pasyente. Yan yung explanation why we need to focus ourselves that the mouth and nose must be closed. Ang tawag doon, closed circuit system. walang paglalabasan ng hangin except through the HEPA filter box of the non-rebreather mask. Of the bag valve mask. Ayan. So dito, sa algorithm, shockable rhythm, ayan, ganun ang gagawin nito. Pag non-shockable rhythm, ang AED sisigaw, analyzing. No shock advice. Continue CPR. Continue ka CPR. Ibig sabihin, ang nakita niya, pwedeng flatline or pwedeng pulseless electrical activity. So yan, no? So itong defibrillator na automated ay hindi siya AI na program lang siya na titingin sa isang shockable rhythm which is ventricular fibrillation and pulseless ventricular tachycardia. Shockable yun. Sa non-shockable rhythm ay marami. Mainly asystole, pulseless electrical activity. Pero dagdagan ko, kung hindi arresting heart, nilagay mo yung AED, kunwari ilagay ko sarili ko, gusto ko mag-commit ng suicide. Ano lang to, kwentong barbero. I don't like to use the word committing suicide, but I want to commit suicide and I will defibrillate myself. Hindi po yan magde-defibrillate sa'yo. Mamamatay ka na lang, hindi sa defibrillator, mamamatay ka sa buwisit. Kahit anong gawin mo. Hindi siya. Kahit papindutin mo yung lightning, yung shock button, hindi yan mo si shock. Okay? So, ganyan ang automated. Yan. So, ito lang ang kabuunan ng algorithm ng basic life support. So, dito balik ako sa shockable. Compress. 30, dalawang hangin. Kinabit si AED, compress. 30, dalawang hangin. Nag-crank up si AED. Pip, 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 sinabayan ko. Tapos pero ako, humihinto ako sa 30, bigay dalawang hangin. Bigla siyang nag-advise ng shock. Analyzing. Don't touch patient. Analyzing, don't touch. Shock advice, stand clear. Shock advice. So, na-shock, boom! Shock given. Continue CPR. CPR ko ulit. 30, bigay ka dalawang hangin. Tapos, after 2 minutes, sisigaw ulit siya, analyzing. Every 2 minutes, magsisigaw siya, analyzing. Shock ulit. So, ganun lang until mag-ACLS na tayo. Pag nag-ACLS na tayo, si AED, hindi siya ginagamit. Para, sa ward, pwede siya mag-AED, pero meron kang manual. Kasi hospital. Sa hospital, manual ang ginagamit na defibrillator. Ngayon, basic life support ka. Wala kang AED, meron kang manual. Walang problema. Ima-manual mo mag-defib. Wala na yung beep, beep, beep. Walang gano'n. So, ikaw na magkukuman. Okay, guys, sige, continue CPR. Paki-time, 2 minutes. After 2 minutes, pads man yan or paddle, pero mayroon pang gumagamit ng paddle. Paddle ako kasi may paddle akong defibrillator. Lagay ko ngayon, switch mode to defibrillation, paddle sign, poop, okay, BF on screen, I'm going to shock the patient, charging now to, kunwari, monophasic, pero ang pinakamaganda, biphasic, or 200 joules. Charging to 200 joules, charging now, tiit, 1 and clear, 2 you're clear, patay yung oxygen, clear, 3 everybody's clear, sigaw yung mga kasamahan ko, clear, tingin sa screen, shock, boom, iwan mo na ako. Tingnan mo ha. Iwan mo na. Titingin sa return. BF on screen, continue CPR. BLS lang yun. Although, sa BLS, ayaw nilang gumamit ng manual. So, AED tayo, pero naka-interface sa manual. Yan. Ganyan ang style. Same thing pag nangyari kapag pediatric patient. Same. Okay? Halos walang pinagkaiba. Ito yung luma na basic life support algorithm, 2015 and below. Ito yung kasama doon. Ito yung 2010 and below. Ito yung 2008 and below. Yan. So these are all the boxes on what to do sa CPR Pag adult, 8-year-old up, tapos child, 8-year-old to 1-year-old. And then infant, 1 year, up to 1-year-old. Yan, ano yung gagawin? Ito yung luma. Okay. Yan, mga two rescuer. Ito yung ginawa noong 2020. Pagpasok ng 2020, hinabol nila to. Ang tawag dito, insert. Hinabol kasi na-release na yung libro. So magkikreate ka ngayon ng insert to coincide with the COVID times. No? So yan. So ito naman, anong mangyayari kapag nagsi-CPR ka? Ang high quality CPR, the pressure in the blood vessel aabot ng 140 to 160 millimeters of mercury. Ang problema ngayon, pag humihinto ka, ayan o, ito humihinto. Walang oxygenation nangyari sa brain. Bibuelo ulit. Bibuelo ulit. Ito yung testimony bakit in-advocate ang all hands CPR. Para ma-maintain natin purely 160. Pag may 160 millimeters of mercury ka, maganda ang oxygenation sa blood mo. Huwag ka lang huminto. Kasi kusa papasok ang oxygen doon sa recoil. So yan yung reality. Kaya nung 2010, hindi na ako advocate ng mouth-to-mouth. So maraming nagalit sa akin na hindi ako advocate. 2010 pa lang, hindi na ako advocate ng mouth-to-mouth. Tapos advocate ako ng all compression. Hindi pa uso ang all compression ng panahon. Kasi naniniwala ko sa compression, bawat recoil, pumapasok yung hangin. Recoil ng thoracic cage. Okay? Now, let's go into choking. Dati, ang choking ay merong tinatawag na mild choking with good air entry, mild choking with poor air entry, and complete choke, no? Or complete or severe choke or total obstruction. Ngayon, hindi na. Tinatawag nilang mild obstruction at saka mapapansin yung mild obstruction, una, nakakaubo pasyente, merong, yung iba merong wheeze, tapos merong noise during air entry. Inhalation, exhalation. So ang ginagawa lang natin ay pinapacilitate yung cuff, pinapaubo. And then while we call for help, pag very insistent na ayaw lumabas ng foreign body airway obstruction. Ang severe naman, merong sense of doom. No? Pakiramdam ng pasyente, mamamatay siya. Minsan hindi nakakaubo kasi hindi nakamaka-inhale ng hangin. Wala siyang iuubo. Wala kang marinig na noise na kasi poor air entry na talaga. Okay, pwedeng completely blockade, wala nang hinga. So yun yung severe obstruction. Mamaya, i-demo ko lang paano natin ginagawa ito. Okay? Kung naturuan kayo na mag-backslap according to Philippine Heart Association, hindi po ini-encourage ng American Heart ang backslap sa adult. Nagbabackslap po. Sa baby, nagbabackslap pero sa center. Sa adult, nagbabackslap sa scapula. Ang American Red Cross ay nagbabackslap. Pero ang American Heart Association, hindi nagbabackslap. So at least yun lang, sino ba ang susundin niyo? So meron tayong mga COE or Center of Excellence, kanino kayo sumusunod? Kung tanungin niyo ko kanino ako susunod, susunod ko kay AHA. Bakit? Si American Red Cross ay walang researching arm. Walang research. Wala siyang researching arm. Ang may research arm, si American Heart. Eh bakit ako maniniwala sa walang researching arm? Doon ako sa merong research unit. Okay? Ito, i-ano ko rin, yung tinatawag na 5x5. I-demo ko na lang yan. I leave the reading to you. Okay? Itong sa infant. Yan. So, dito tayo sa AED. So, depende sa gamit, depende sa anong klaseng AED ang ginagamit. Kunin ko yung AED ko ha. Wait for a while. So, ito yung AED ko. So, may dalawa akong automated. Yes? Okay. Meron akong Sol Pro. Tapos, in-sponsoran ako ng Mindray. Itong Mindray, na-adjust ang joules.
Powered on. Stay calm. Follow the instructions. Remove clothing from patient's chest. Apply pads as shown on pads.
So, meron siyang
Remove clothing from patient's chest. Apply pads as shown on pads.
So, i-apply ko tong pads. So,
Remove clothing from patient's chest.
habang hindi ko
Apply
ginagalaw,
pads as shown on pads.
so hindi siya hinto. Tapos, ang maganda sa
Remove
kanya,
clothing from patient's chest.
meron siyang
Plug
pangbata,
in pads connector. Child mode.
child mode,
Adult mode.
adult mode. So, ang bago,
Remove clothing from patient. Child mode. Adult mode.
trying ko na kasi maingay, paulit-ulit lang. Hanggat hindi ko tanggalin yung pads ilagay, hindi siya hinto. Buy-buy-sitin na lang ako paulit-ulit. Ang bagong AED may child mode saka adult mode. So, ito bago na. Okay. So, depende sa brand, dalawa yung switch. Katulad noon, katulad ng AED ko, wala siyang on and off. Ang on niya ay nasa cover lid. Kusa siya mag-on.
Powered on.
Powered
Stay
on.
calm.
Okay.
Follow the instructions.
Yan. Yung iba naman, katulad ng Zolco, i-on mo pa, pindutin mo. Unit okay. Apply patch. Yan. So, depende yan sa unit. Tapos, of course, it has capability to analyze shockable rhythm versus non-shockable rhythm. Pag shockable rhythm, syempre, mag-utos siya mag-shock. So, ang AED is not rocket science. To tell you, ginawa siya para sa lay people. Okay? So, again, ang operation niya pwedeng button or pwedeng cover or yung faceplate. Kung merong mga medication patches, tatanggalin natin na medication patches. Kung galing nalunod, linisan natin. Ang AED ay merong kasamang towelet, dry, at saka razor. I-razor lang natin yung lalagyan ng patch. Okay? Ito wala eh.
Powered on. Stay calm. Follow the instructions. Remove clothing from patient's chest. Apply pads as shown on pads.
So, linisan muna kasi pag hindi malinis, hindi siya makapag-detect ng maayos. Okay? Pag tanggal ng pads, pwedeng detachable pa, independent pads, hiwalay sa sternum, hiwalay sa apex. Or continuous pads, katulad ng zone. Sternum, apex, merong sensor sa gitna. Doon nilalagay ang kamay, pang compression. Okay, ganyan. And then, pag sumigaw siyang shock advice, stand clear or stay clear. Ikaw naman, sa hospital, ang chanting natin ay tatlo. One, I'm clear. Pag one, I'm clear, tiningnan ko ang sarili ko na hindi ako nakatouch sa pasyente. Two, you're clear kung may airway, titingnan si airway. Be sure oxygen ay zero. 3, everybody's clear, head to foot sa pasyente, be sure ang hospital staff or kamag-anak ng pasyente ay hindi nakahawak sa pasyente. Then, pagbigay ng shock, no? Shock advice. Kung shock, pag hindi shockable, no shock advice. Continue CPR. So, pagbigay ng shock, ang AED sisigaw siya, shock given. Check for pulse or continue CPR. Depende anong utos niya. So, continue CPR ka na. Or mag-check ka if there is pulse. Okay? So, ganun lang siya. Dalawa si AED, voice prompt at saka picture on where to place the pads, on usually where to place the pads, yun yung picture niya. Sa bata, meron tayong child pad. Maliliit siya. Okay? Pero pag hindi, ginagawa natin harap-likod. Dati, sa adult, sternum apex. Sternum apex. Sa bata, dito sa sternum, dito banda, dito banda. Tapos sa likod, sa may scapula, harapan, ang tawag doon sandwich. So ayun, yung iba center, okay lang. Depende sa laki ng bata. Pag malaki na yung bata, na adult positioning siya. Sternum apex. Pag maliit siya, sobrang liit, pwedeng sternum center, tapos sa backbone. Ayan, katulad yan. Pag drowning, dry the patient, tapos huwag kayong mag-defib sa gilid ng swimming pool na basa. Kailangan dry. Baka magmali ng basa si AED. So, dyan yung delay konti. Bilisan, i-dry ka agad ang pasyente. kahit ang i-dry ay ang patungan lang, I mean yung likod, naka-short siya, basa, huwag mo nang pansinin yung shorts. Dibdib at saka likod, dry. Ang patungan niya kung pwede, long backboard, plastic, or kahoy. Pero pag semento mo siya ipatong, be sure hindi basa ang semento. Pag hairy, dalawa lang yan. It's either mabilisan erasure or social to social. Lagyan mo ng defib pads, tapos bunutin mo, tanggal ang balahibo. Panibagong defib pads na kung mahal. Kung Zolian mahal, sa US pwede. Kung mabilisan. Kung gusto mong mabilisan. Kung hindi, during nagsi-CPR ka, may nagsishave na kasama mo. Hindi mo i-shave ang buong dibdib. I-shave mo lang yung upper right of sternum kasi doon mo ilagay ang pads. No? Siyempre dito sa apex, halos walang balahibo na. Okay, no need, basta doon sa mabalahibo part. Pag may pacemaker, karamihang pacemaker ang nasa upper left, hindi siya tatamaan ng pads ng AED. Ang pacemaker usually nilalagay sa upper left. Ang left side ng AED ay nasa apex, malayo siya sa pacemaker. Pag merong mga brass, huwag ipatouch sa metal ang pads. So tatanggalin, may gunting, tanggalin natin yung mga metal clip sa bra. Pag jewelry, huwag natin tanggalin. Pero kung ang jewelry katulad dito, ganyan na ka-exaggerated, tanggalin natin mga ka-apekto. Pero, pwede ka mag-AED, kung it takes time removing the bling-bling niya sa katawan, mag-AED ka. But it might really affect, no? Pero, hindi ko sinasabing totally it can affect kasi tulad sabi ko, ang electricity dapat mayroon siyang conducting surface. Yun lang, pag nag-AED ako, kakainin ng ibang energy ng bakal. Kasi mas highly conductor ang bakal kesa sa tubig na nasa loob ng cells natin. Now, let's go into naloxone. Ang available naloxone sa Pilipinas ay intravenously given. Narcan. So, ginagamit natin siya pag unintentionally na opioid overdose kasi nagbigay ako ng sangkatutak, morphine, na overdose siya. Nag-respiratory depression. So, bigay akong Narcan to reverse it. Nakita nila na dapat sa basic life support pa lang, nabibigay na si Narcan. So, gumawa sila ng atomizer or nasal spray. Yan. No? In-insert sa ilong, tingnan nyo to, parang ganito. Insert sa ilong. Insert sa ilong, spray. Yan, atomizer. Kung makita nyo sa picture, yan ang mist. Although sa libro wala namang sinabing atomizer. But the water is atomized. Atomized. So, ginamit ko yung word na atomized. So, si Narcan ay 4 milligrams. Si Cloxado mas mataas, umaakyat siya ng 8 milligrams. Okay. So, sikat si Narcan. Kasi siya yung naka-take off una. Ngayon, no amount of CPR and defibrillator if the patient is intoxicated, is having overdose of opioids. Hindi, pag nagkaroon ng respiratory arrest, tapos cardiac arrest, hindi mo mabubuhay yan. Babalik at babalik arrest because the drug is there. Okay? So, useless. So, nakita nila, kailangan talaga mag-Narcan ka. Kaya gumawa sila ng formulation, nilagay sa intranasal spray. What's the presentation of the patient? The patient will show respiratory depression, CNS depression. So, para siyang obtunded up to the point na maging comatose siya. And that is an emergency. So, kailangan natin i-reverse. Pero sa mga tao na conscious, no? Pero opioid overdose suspected, huwag kang basta-basta magbigay ng Narcan na walang pulis kang kasama. Bakit? Bago nag-addict yan, pahirapan niyang kinuha yung drugs. Uhulihin siya, hindi naman legal eh. Ngayon, babasagin mo yung trip niya. I-reverse mo yun. Sasaksakin o umbagin or barilin ka ng pasyente. Kasi tinanggal mo yung trip niya sa buhay eh. Kaya pag ang pasyente hindi pa arresting, responde kayo, nakakita kayo ng intoxicated or overdose with drug, huwag kayong basta-basta magre-reverse na wala kayong kasamang pulis. Magwawala yung pasyente. So, paano natin binibigay? One spray, intranasal. Tapos, pwede ka magbigay ulit. Kung sa tingin mo hindi nag-reverse, bigay ka ulit. Pero tatawag ka ng online medical control. So, ganyan forma. Ewan ko kung maintindihan nyo sa drawing. Ayan. No? So, pinupost natin yung atomized substance towards the turbinates. Okay, then after 2 to 3 minutes, pwede ka mag-additional dose new spray ulit. Kasi isang use lang yung isang spray. Pag walang response, additional dose every 2 to 3 minutes. And with the guidance of with the medical personnel, kung ikaw ay non-med. So dagdag ka lang ng dagdag ng naloxone, but you have to seek clearance while you add. Okay. So I will not discuss so much. I'll go into 10 commandments. What do you do? Nagkataon, nasa labas ka, nasa field ka, at nakakita ka ng taong nag-arrest. So ituturo ko yung the 10 commandments. The 10C, letter C. Sa Philippine Heart Association, may sinusunod silang 5C. Call, cover mo yung mouth and nose. Compress, sorry. Call for help, cover, compress, correct, kalimutan ko yung basta 5. Hindi ibig sabihin magaling ako kasi 10. Kinumpleto ko lang cover the COVID issue nung kasagsagan ng surges ng COVID. So ginawa ko siyang 10 commandments. Number 1, pag may nakita kayong kaso sa field, consider it to be COVID positive. Suspect mo na kayo, positive sa COVID, para hindi kayo kukumpiyansa. Number 2C, kung ikaw ay healthcare provider at maraming usyosero nakapaligid sa victim, mag-abiso ka, ang tawag doon check-in. Ang word na check-in ginagamit sa ICS, Incident Command System. Gagamitin ko rito. Ganito mag-abiso. Nurse po ako, pwede niyong sabihin yon. Or sa rescue po ako, pwede niyong sabihin yon. Sa rescue po ako, baka po ako makatulong. Ganyan lang. Wala na maraming istorya. Hindi ko kailangan ng mahaba mong pangalan. Hindi ko kailangan ang serial number or PRC license number mo. No way. Sa rescue po ako, baka po ako makatulong. Ganun lang kasimple. You check in, abiso ka. Bakit? Although hindi applicable sa nurses, doctor, kasi may PRC ID tayo, walang good Samaritan law sa Pilipinas. Pwede kang madali doon, although tayo hindi. Kasi healthcare provider, meron na tayong license. Next is crowd control. No? Maraming osyosero, papaligiran ka, pwede mong utusin. Bigyan niyo ako ng hangin, although wala siyang kasayan-science, pero yan yung way maintindihan ng Pilipino. Paluwang po, bigyan niyo ako ng hangin, pasuyo, paayos sa trapiko. Yan. Kasi baka may COVID doon, mag-super spread tayo. Although meron ng herd immunity. Number 4, check hazard. Ano ang dahilan? Bakit siya bumagsak din sa kalye? Nandyan din ang dahilan. Nabugbog ba siya? Nasaksak? Nabaril? Or sa loob ng pamamahay na kuryente? Nandyan din ang kuryente sa paligid. So you have to check your hazard. Then, check for responsiveness. Pag nag-check kayo, tap the shoulder. Tapos, pinch the shoulder, yung trapezius. Mamaya i-demo ko. Pag pinch yan, masakit po yan. Pero pag i-pinch ninyo ang sarili ninyo, hindi kayo makakaramdam ng sakit. Pero subukan nyo i-pinch yung iba. Pag pinch ganun ha, huwag kurot ha, ang pinch ganun. Pag pinch ganun, masakit yan. Kung iba ang mag-pinch sa'yo. Sakit yan. Siyempre, pag gumiwi yung muka, responsive to pain yun. So, no need to CPR. Gising ang pasyente. So, hindi lang call for help, tapping the shoulder, but also pinch. Incidentally, the patient is unconscious. Number 6, call for help. Call 911 or any local number. Tandaan nyo, out of hospital. Before you start CPR, cover with surgical mask the mouth and nose of patient. Yan. Hindi lang nose ang kinuberan or mouth ang kinuberan. Yung dalawa. Next, start compression at 120, at 100 to 120 per minute. Pag dumating si AED, connect to AED. Letter C, connect to AED and follow voice prompt. Dahil kasagsagan ng COVID, hirap ang ambulance, pwede kang mag-request ng jeepney or what para isakay doon. Ang tawag doon, case evacuation. Ang case evacuation sa military term yan, nag-evacuate ka ng wounded soldier using a non-medical transportation. Katulad nito, totoo po ito, alas 3 ng disgrasya, alas 5 pa kami nakahanap ng sasakyan. Pick up para magdala sa ospital. Kasi walang ambulance, dedicated lahat sa COVID. So, kailangan marunong kayo mag-case evac. So, isasakay, papunta sa ospital. Kasi sa military, pag wounded soldier, no, sundalo, wounded siya, nilagay mo sa ambulance, ang tawag doon, tactical evacuation. Nilagay mo sa loob ng jeep na hindi ambulansya, ang tawag doon, case evacuation. Kaya, nag-comply tayo ng 10C. Ulitin ko. Number 1, consider everyone to be COVID positive. 2, check in to the group, to the crowd. 3, crowd control. 4, check hazard. 5, check for responsiveness of the patient. Patient is unresponsive. Number 6, call for help. Then, before starting CPR, cover with mask the face, the nose and mouth. Then, compress 100 to 120 per minute. Then, connect to AED kung meron. Then, case evacuation to the nearest hospital. That is the 10C, ladies and gentlemen. Hanapin niyo sa internet. Siyempre wala dahil ginawa ko lang yan. So, sa BLS, included na rin sa bago, understanding stroke, but in the basic sense, because there's nothing you can do with stroke. So, ano kailangan malaman sa stroke? Alam niyo lang na ang individual ay may stroke. Gagamitan natin ng Cincinnati Pre-Hospital Stroke Scale. Ano yung Cincinnati? Yan yung FAST, F-A-S-T. Pero may bago ngayon, nadagdag ng BE. So modified na siya, stroke scale. Modified from Cincinnati Stroke Scale. Okay? So ano yung B? Tatlo yung B. Suddenly, there is loss of B, balance. And or, nagkaroon ng lapse in memory biglaan. Ang tawag brain fog. Brain fog. and or ang ugali nag-iba, biglaan lang. Kasi ang ugali, hindi yan biglaan. It takes time. Biglaan, parang hindi mo makausap, masungit. Yun pala, may nangyari na stroke na. So, and or. Tapos, and or ulit, E, eyes. Blurring of vision. Suddenly, merong loss of vision. Loss, blurry. And or F, facial asymmetry. Tabingi yung isang mukha. And or A, arm and leg weakness on one side. And or S, there is slurring of speech. Ladies and gentlemen, time factor sa ospital, bilisan nyo. Kasi the more bumabad matagal yan, kawawa yung brain. Baka partially, ano lang siya, biglang lumala dahil mabagal ka. Particularly if it's like a bleed form of stroke. Okay, ito yung isang emergency ako during COVID times. So ito po ang assembly ng ACLS. Pero pag BLS, tatlo lang. Airway, compression, defibrillator. The team leader ideally must come up with with plan. Nag-usap sila habang nagpapalitan. Walang IV meds at walang leader. Walang IV meds kasi basic lang yan. At ang leader ay integrated na, it's either the defibrillator or the airway or the compressor. When do we stop CPR? Hindi lang pwedeng CPR hanggang Pasko. So, kailan tayo hinto? Tandaan niyo lang yung stops. Letter S, spontaneous return of breathing and circulation. Natauhan na, revive na siya. T, transfer to high level of care. Kunwari, nurse ka, dumating yung doktor, o di transfer mo na kasi mas higher ang kanyang. So, this transfer is depende kung sino respond. First aider ka, dumating EMT, turn over mo sa kanya kasi EMT siya. Mas mataas siya sa iyo. Then, operator is so tired. Di na kaya. P, physician's advice. Siyempre, sundin niyo, doktor yan. Sabi ng doktor, guys, stop, no more na. Stop ka na. And then as scene becomes unsafe. Kunwari, nagsi-CPR ka, biglang may nagrambulan, nagsasaksakan. Hinto ka. Kunwari, nagwala sa ospital or may nasunog biglang ospital, sumabog. Hinto ka. Evacuate ka. Kung kaya, evacuate with patient. Pag hindi, at least ikaw buhay. So if the scene becomes unsafe, you stop CPR and find the safe area. What if nakabasag ka ng rib? So there's an article in the revised penal code, Article 12, paragraph 4. Any person who, while performing a lawful act with due care, so tayo yon, causes an injury by mere accident without fault or intention of causing it. So it's about the circumstances which exempt you from criminal liability. So huwag kayong mag-aalangan na makukulong kayo. Kung nabalik yung rib, continue pa rin ang CPR. Kasi pag uli ka mag-continue, mamamatay yan. So nangyari yan, there was one, kailan ba yun? Na bumangga siya sa gilid ng sasakyan. Tawid siya. Hindi siya head-on. Siya bumangga sa speeding truck, sa speeding vehicle. So, bagsak siya. Tapos warak yung dito sa dibdib. Nag-perform ng CPR, okay naman eh. There might be some complication, but if you do not compress, mas malalo siyang madalis mamatay. So you can still perform. (85 to 90% of arresting patients will show ventricular fibrillation. Mas ma-explain ko yan pag nasa ACLS na. So itong mama na to, bumulagta sa parola, nagtuturo ako sa counter-terrorist unit, pinatawag po ako. Kung nakita ko bumulagta, I started CPR, tapos yung mga co-instructors ko nagdatingan. May nag-CPR na, kinuha ko yung defibrillator. Yung defib ko, nakita nyo dyan, matagal kong iniiwan sa sakyan, nasira yung LED, yung display. Kaya huwag kayo mag-iwan ng electronic na mayroong LED, sisirain ang init. Lalo na direct under the sun. Whatever happened to it, it's still fired as a defibrillator at nabuhay yung mama na yan. Just this year, yung kanyang classmate, kasi Navy yan, Coast Guard Navy. Na-meet ko sa airport sa Lagindingan, nilapitan niya ako, sumalot siya, "Sir, thank you for saving the life of my bangki." Di ko naintindihan until tinuro niya tong picture. Ay, yung picture na meron siya, yan po sir, yung kinunan po kitang picture. So we don't know, no? Kalaki-laking mama nito, Navy pa siya, nadali siya. Okay, so that ends my presentation. I'm gonna give you a 15 minutes break. Then we will go into what they call this practical application. Okay? Question. Walang tanong? Okay, walang tanong. I'll meet you after 15 minutes for a demo. Okay? So take a break, guys. Okay. So, balik tayo. Now, we'll settle first choking. A person who choke doon sa oropharynx is above the supraglottic. Bumara. Pwedeng bumara, depende sa laki, hindi mailunok ng esophagus, humarang anteriorly, kaya na-choke. Merong choke na mismong doon mismo sa ibabaw ng larynx, lalo na may mga buto or hard meat. No? Now, if the patient can breathe, stay on the side. Tingnan niya, nasa side ako. Stay on the side. And alam ko mahirapan siya, pero bulungan mo, hinahinay, magsabi ka, inhale slowly. Tapos, buga. Tapos, inhale sa nose, wag sa bibig, para hindi siya ma-encourage huminga mabilis. 3 seconds. Ganon. Pag up, lock, ipapacilitate mo cup, isang cup o dalawang cup. Ganon, sige. Cup. Pasin mo, hindi slap, kundi facilitate cup. Okay. Pwedeng magluha-luha yan. May sound konti. Exhale, inhale. Cup. Sige. Ayan. Ganun ka lang until the foreign object is being expelled. No? Or until it results into a complete block. Kasi pagpabayaan mo yan, pero habol yan hinga, pag higop niyang hinga, babara yan. Kaya tinuturuan natin, Paano huminga ng alalay lang. Okay, dito tayo nagkakamali. Doon sa first episode na kung saan hindi siya magkakaroon ng total blocking or a severe block. Hinga, kap, okay. Hinga, na lang, buga, hinga sa ilong, okay, kap, good, kap, ganon, hinga. Buga, sige, buga po, hinga ulit. Okay, sige, buga ulit. Yan. Kap, kap, sabay buga sa kap. Para meron siyang cadence. Hindi yung lawgaw. Pag sige sa kap, ang tendency niya, hihinga yan ng mabilis kasi wala ng oxygen. Eh. Sabi ng brain, kulang ako ng oxygen, hihinga siya mabilis. The block might go inside. Okay. So, total blocking, hawak na yan or hahawak sa'yo. Sa akin, meron isa. Of all people na ito, hindi ko makalimutan. Kasi ang laking mama. Painumin niyo muna. Tumulo pa. Laking mama. Ibig sabihin, mahirapan ako kasi malaki sa akin. Malaking mama, pangalawa, doktor. Doktor siya. Hawak talaga sa akin. Malaki. So, mahirapan ako. Pero sige lang. No? Ginawa ko. Hindi ko kaya. Pinaupo ko lang. Pag bumagsak, nakaupo. So, nakaupo siya. Pinasisyon ko sarili ko. Okay, know what to do. Hawak siya. Dito ko sa gilid. Bitawan kay let go of me. So, hinawakan ko siya dito. 1 or 2 finger from the xiphoid process. Gawa akong ganito. Kailangan ang kamay nyo sanay gumawa left and right. Yan, tingnan nyo ako. So, ito ay right, left. Ito left, right. So, it should like you have to create some sort of a inward push yan, towards the scapula of the patient. Huwag niyong gawin sa bahay to kasi susuka talaga. Yan, 1, 2, 3. Okay. I'm gonna tell you, kahit nurse, doctor, cuff yan, if it takes a hard time to remove the blockade, natanggal na, huwag kayong masaya, dalhin nyo sa ospital. Baka magkaroon niya ng laryngospasm, may irritation. Kasi it took hard to remove. Okay, rule number 1. Rule number 2, if the blocking object is irregular, that cause irritation. Okay, may irritation. Merong, paglabas doon, may mga dugo. 3, pag ubo niya, natanggal, merong blood ang laway. Bring it to the hospital kasi merong injury. So it might not result into some sort of a laryngospasm, but it might, of course, infection. Alam niyo naman, mas maraming bacteria ang mouth kaysa sa anus. So marumi, no? Kaya medyo pupunta doon. So tendency for infection is of greater margin. So yan, ha? So huwag kang hihinto hanggat di na, no? What if wala talaga? Tapos the patient nawala ng malay, nakatayo kami. So yung paa niya, kung nakatayo kayo, yung paa mo to. Yung isang paa mo, ilagay mo sa middle. Tapos pag nawalan siyang malay, pa-slide mo lang atras ka. Para hinahinay siya, mag-slide down. Kasi pag nakaganon ang paa ng pasyente, tapos dead weight siya, tapos ang paa mo nasa labas, pag mabigat yan, biglang sumayaw yan sa gilid, bagsak kayong dalawa. Tapos nakukunan pa kayo ng video. Viral ka ngayon, sikat ka doon sa buong Pilipinas, buong mundo. So para hindi matumba, lagay sa gitna. Ang isang paa mo, sa labas ng paa. Para pag ganon, slide siya. Slide ang pasyente. So pag na-slide na, dalawang books ang susundin na. So mamaya ide-demo ko pag nasa ground. Okay? Pag baby, nawala yung baby ko. na dami. Hiniram. Sa baby, choking, mahirap kasi baby can't communicate. Start na lang and then, para malaman mo may choke, the nanay will tell you, meron na choke. Or else, di mo alam ano yung baby, baka alam mo epilepsy because the baby cannot dramatize it. That's the real thing. I saw it. Nung ako'y intern, isa sa first case ko, choking. Kaya hindi ko siya makalimutan, baby. Baby, ganun lang. Buti, kita ko yung choke. Kasi meron daw nailagay eh. So, hirap tanggalin. So, kailangan i-hook. No? Ginanong ko pa. Gumagano. Ibig sabihin, tapos, pagtanggal talagang, parang nangingitim, no? Pagtanggal talagang grabe iyak ng bata. So, dinala namin sa Nico. Okay. So, hindi ko makalimutan yun. So, hindi ko nakuha. Tapos, yung isang doktora, pedya, kumuha talaga siya yung, this kind of forceps, no, na with eye, malaki. Yan ang ginanon. So, sa baby, pag wala, chest compress sa chest, sternum. 1, 2, 3, 4, 5. Hawak dito. Taob. Baba ang ulo. Back slap. Sa gitna ng spine. Ganun ang kamay. 1, 2, 3. Papunta sa taas. Para hindi tama ng ulo. 4, 5. Hawak dito. Mabilisan. Lagay sa table. Paglagay sa table, pwedeng ito nasa ilalim ng chest. Parang gano'n. 1, 2, 3, 4, 5. No? Ganun na lang. 1, 2, 3, 4, 5. Tapos pag 1, 2, 3, 4, 5, nakatingin ka. Pag nakita na, yakapin mo konti, kunin mo. Huwag ka mag-blind sweep. Seldom you can see choking sa infant. But, I cannot forget the first time I saw that. For the years of my practice, I never saw anymore. But I will not forget. Then back slap. 1, 2, 3, 4. Ang tawag nito 5x5. Okay, now let's go to the ground on how to do it. So ngayon na-choke, nasa ground na. So dalawang ituturo ko. Yung Netherlands style, DTL, Disaster Tech Lab, saka American Heart. So itong pasyente down na. Hey. Ito yung trapezius pins. Unconscious. Activate emergency response or activate code blue. Kung sa hospital, code blue. Ngayon, check. Do not blind sweep again. Ayaw ko ini-encourage kasi baka kulang na oxygen, mag-seizure, nakagat yung daliri mo, patay. So, hindi ko ini-encourage manipulation. So, start compression. Tinatawag na give 5. 1, 2, 3, 4, 5. Hinto lang, silip. Kasi sa totoong buhay, ang dead weight, ganon. Or ganon. Ganyan ang dead weight. 1, 2, 3, 4, 5, silip. 1, 2, 3. Ito yung 5. Ang AHA, continuous. Okay, continuous until pagdating ng code blue, maglagay ng non-rebreather mask or what ang ilagay or mag-bag valve mask. Mamaya tuturuan ko kayo pa ng mag-bag valve. Pag lumabas yung foreign body, bilisan, hindi na matagal. Baka sumuka yan. Sige. Okay? Then, monitor vital signs and what? Refer to ENT, kung ano man yun. Okay? Hindi pwedeng pauwiin kung kayo ay nasa out of hospital. Sa in-hospital, syempre repair kasi complete blockade na yun eh. I don't know what's gonna happen. Yan. So, ganun lang tayo. So, merong DTL na 5. 1, 2, 3, 4, 5. Post, Philip. Disaster Tech Lab yun, Netherlands. Ang American Heart Association, tuloy-tuloy lang. 1, 2, 3, 4, 5, 6. Continue CPR siya. Until the patient caps it off. And, or natanggal plus return to spontaneous circulation. This is your bag valve mask. walang pang-COVID, wala siya ganun. Karamihang mali na ginagawa ninyo sa ospital ay ganito. Nilalagay lang si Apex, si base, nilalagay lang ganon, tapos mask. Mali po yun. Tatlo ang pupuntahan ng hangin. Nag-mask. Tatlo yung pupuntahan ng hangin. Pupunta yan sa lungs, pupunta yan sa stomach, or pag hindi maganda ang seal, magbe-bleed yan sa gilid ng face. The proper handling or operating a bag valve mask is employing the C and the E. Tingnan nyo kamay ko. The C and the E. Si C ay nandito sa junction. C. Tanggalin ko muna. Pihit ko sa inyo. Yan, junction. Si E, sorry ha, tanggalin ko ulo. Yan ang positioning, apex, the base of the triangle. C, ang E ay nandito sa bony, inferior bony margin of your mandible, si E. Si mandible, yan. Huwag sa gitna, hindi makahinga yan. Sa bony part, ito si C, ito si E, maglalak. Yan ang tinatawag na single hand lock. Ang double hand lock ay under C and E, and hyperextend kapag hindi walang cervical spine injury, suspicion of cervical spine involvement. Kapag single-handed, balik ko ulit, balik ko. Pag single-handed, nasa table yan, itong ulna nyo ay ulnar bone, noo, yan, and then hyper extend. Pag naka-hyper extend yan, the cartilaginous cricothyroid cartilage will be pushed posteriorly. Iipitin si esophagus against the anterior hard border of your cervical spine. Therefore, pag ginanon ko to, hyperextend, kahit subukan nyo ngayon, tumingala kayong lahat, tumingala kayo, lumunok kayo, hindi kayo makalunok kasi sarado si esophagus. The objective is to give oxygen mainly to the lungs na hindi mapupunta sa tiyan at magkaroon ako ng gastric insufflation. Yan o, tingin nyo. Kung hirap kayo, lagay kayo ng Totsirol. Kasi yung cardiac board, automatic tataas yung dibdib, ang ulo mag-hyperextend. Wala. Pwede kayo maglagay ng Totsirol. Anything na ilagay nyo, parang unan-unan, para mag-hyperextend si neck. Yan. So, unan-unan na flat. Cardiac board or unan dito sa nape para makapag-hyperextend. Hindi effort pala. So, yan, hyperextend. Pag driving nyo, automatic sa lungs yan. Wala sa tiyan. Because the esophagus is locked in that manner. Okay. Question. Anong question? Now let's go into CPR. The patient in the ward, male ward, becomes unconscious, sigaw si kamag-anak, si bantay, nurse, 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 yung tatay ko, bakit walang malay? Takbo ngayon si nursing aide or si nurse. Pagtingin niya, check for consciousness, hey, 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 tay, 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 unconscious, sigaw ka, unconscious patient, bed number 3, bed number 3, code blue to, okay? Hindi siya nag-react, pag hindi react, activate code blue, check for pulse, 1,000, 2,000, 3,000, kasi healthcare provider ka, 5,000. Habang ano ka, tawag ka na kung merong intercom or what. Dala ng crash cart ka rito. 10,000 no pulse. Pag no pulse, bagsak ang habang nagche-check ka ng pulse, bagsak si bed habang nagche-check ng pulse para ang tawag doon is overlapping. Tapos prepare si cardiac board. Okay? No pulse ako. Pag start ako compression, insert si cardiac board. Yung cardiac board. Insert si cardiac board. Non-rebreather mask. Kasi nag-isa pa lang ako, non-rebreather mask, iwan ko yung non-rebreather mask. No? Mamaya pakitaan ko na non-rebreather mask nakahook sa 15 liters of oxygen. Okay? Non-rebreather mask nakahook sa 15 liters of oxygen. So yan ang ating style. Para pag nag-CPR ako, yung aerosol hindi pupunta sa atin. Interim guidelines of 2022. Ito pag gusto nyong sundin. Pero kung ideal tayo, yes. I know you have problem with a non-rebreather mask. Pangalawa, you have problem with an emergency oxygen. Karamihang oxygen ginagamit lalo na peripheral hospital ay medical oxygen. Hanggang 10 liters lang na dumadaan sa humidifier. Ang emergency oxygen ay hindi dumadaan sa humidifier. Merong 15 liters per minute. Kung meron namang isang airway kasama mo, maglagay mo na siya ng bag valve mask bago ka mag-start ng compression. So, nag-compression ako. 1, 2, 3. Lagay ko lang dyan lang. Hindi nakabitaw. Ganun ko lang kasi wala akong kasama iba. Sorry ha. Tanggalin ko lang yung kasi wala akong kasamang iba. Solo lang ako. Nakaganon siya. Lagyan ko ng tukod. Hirap na walang kasama yan. So, tuloy ko. 2, 3, 4. 8, 9, 1, 0. Pag nag-count kayo, huwag kayo mag 10, 20, 11, 12, 13. Maubusan kayo ng hangin. Laging 1, 2, 3, 5, 7, 8, 9, 10. 1, 2, 3, 4, 6, 9, 21. 5, 6, 7, 8, 9, 30. Bigay siyang dalawa. 1, 1, gano'n. Dumating si AED. So, habang nagko-compress ako, dumating si AED. Yan. AED. Ito yung AED na, saan ko ba ilalagay para makita niyo? Dito na lang. Baliktad ko. So habang nakikita. So habang nako-compress ako, AED on. Unit okay, apply pass. Tuloy-tuloy lang ako. 30, boom, boom. Walang interruption, lagay dito sa shoulder, lagay dito sa apex. Pam, 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 pam. 30. Tapos si AD nagsasalita siya. Pag nakarinig na kay pip, pip, sundin niyo na yun. Pip, pip, 30. Pip, 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 pip. Bigay siya. 1, 2, pip, pip, pip. After 2 minutes analyzing, bumitaw ka. Bumitaw. So natanggal si Patch. Ayaw kong gamitin yan. Tanggal siya. No? Analyzing, huwag mong hawakan ng pasyente. Shock advice. Dito ako compressor. Pag shock advice, stand clear. 1 and clear. Ang sisigaw ng si electrical therapist. 1 and clear. 2 year clear. Naka-zero si Treble is clear. Sigaw na clear. Shock, boom. Continue CPR. So, CPR, kaya ko pa naman. Okay? Kaya ko pa. Pwede ring interruption konti. Lilikod ngayon lilipunta sa likod. Mabilisan lang. Alis ako. Bigla siyang swap. Ngayon, biglang sinabi analyzing. Bitaw ulit. Shock advice, stand clear. Lahat ng AED merong pula. May lightning. Usually may lightning. Yan lang pindutin. One and clear. Two you're clear. Clear. Three clear. Clear. Pag pinutin po, sisigaw si AD. Shock advice. Check for pulse. Oh, check for pulse ka. May mga AD may check for pulse. Karamihang AD walang check for pulse. Okay? Karamihang AD ang sasabihin, check for responsiveness. Kasi dinisign lang siya pang no response, continue CPR. Yan. Yung typical AED ganito. Analyzing. No shock advice. Kunwari, meron ng pulso. Sisigaw siya, no shock advice. May pulso na. Wala, hindi siya sisigaw na may pulse. No shock advice. Check responsiveness. Diyan ka ngayon mag-check. Kung marunong ka mag-check ng pulse, will not will not give us. Okay? Ang dami tanong ba? Ilan po ang laman ng air ng BBM? Ito siya, this is like a 1 liter, no? Ang ibibigay lang natin is 600. Ang 600 itansya nila. Tansya. Yung iba is 800. Yung iba kasi depende, 800, ito 1 liter. Pero ang tansya niyo is 600 kasi ang lung capacity ko is 600 to 700 ml. So yun. Ganyan ang bigay natin. So kailangan meron kang reservoir nakakonect sa oxygen para ang delivery niya sa 15 liter supply, umaabot siya ng 95%. 95. Maganda binibigay sa arrest na mayroong oxygen. Huwag tayong masanay magbigay ng BBM na wala to at hindi nakahook sa 15 liters per minute. Useless yan. Pag nakunan tayo ng video, pagtawanan tayo ng mundo. Sa arresting, nakahook dapat ang BBM sa 15 liters per minute na oxygen supply, tapos mayroong reserva kasi mapupuno ng hangin. Ito yung magpapabigay sa atin kaya akyat tayo ng 90 to 95% of oxygen. Do not hyperventilate, huwag masyadong every 4 seconds, kundi every 4 to 6. At huwag mag-hyperinflate. Tama lang? Kasi baka mag-hyperinflate, tapos matanda ako, biglang sumabog yung aking lungs, magkaroon ako ng pneumothorax. Okay? Paano kung dahil hospital tayo, hindi AED, anong ginagamit natin? So, ang ginagamit natin ay manual. Okay? Manual defibrillator sa BLS. So, ito, pag nagmamanual defibrillator tayo, aangat na tayo to ACLS. I will demo it sa ACLS na. Aangat na tayo. Kasi after that, magre-require na ako mag-IV na eh. Mag-airway na. Dito, defibrillator na naka-attach sa manual defibrillator yung AED. Yan yung bago ngayon. Wala tayong magawa. Yan yung standard. Hindi pwedeng lumang gamit sa bagong karunungan. Hindi din pwedeng gumamit ng bagong gamit sa lumang karunungan. Kailangan makabagong karunungan sa bagong gamit. Once you have your ACLS this afternoon and tomorrow, makikita nyo the importance ng may magagandang gamit like capnometry. Wala lang akong tamper eh. Yan ang wala ko. But I have everything. So, hindi pa ako believer ng tamper. Okay? So, again, ano ang start-up ng compression? Hindi ka pwede mag-compress according to interim guidelines na walang mask or walang bag valve mask or a non-rebreather mask to discourage the expulsion of aerosol. 2, the AED will follow suit pero hindi natin siya susundin sa lahat. Ang susundin lang natin kapag sumigaw na siya ng analyzing. Wala akong hawak. Shock advice. Stand clear. So, option ako. 1, I'm clear. 2, you're clear. Patay yung clear. 3, everyone is clear. Clear. Shock. Boom! Shock given. Continue CPR. CPR ulit. Oxygen ulit siya 15 liters per minute. Ganyan lang. Until the patient goes back to life or the patient is elevated into ACLS platform, which will happen this 1 o'clock in the afternoon onwards. Okay? Question. Kung nalukson induction yan, bigay tayo nalukson. Kasi hindi ko mabubuhay yan pag walang nalukson. So, arresting patient, bigay nalukson. Drive. Isang drive, 4 mgs Narcan. Sige, tuloy-tuloy. Kung arresting CPR, walang pagbabago. Pag fire isa, wala pa rin, hindi nagawan, second drive ka. Ang drive mo, every 2 to 3 minutes, drive ka ulit. Until the patient goes into ACLS or goes back to life. Yan ang ating basic life support. Any question? Good, we have doctors. By the way, tomorrow, ang first aid ninyo, I'll give you justice, is a first aid na hindi niyo pa natutunan. Kasi, sorry nasa meeting ako the other day. Saturday ngayon, no? Thursday, had meetings Malacanang. Gustong i-standardize, sabi ko i-standardize ko yan. Once, kasi hindi, kinukuha ko mag-undersecretary sa Executive Order 34. The problem is, ayaw kong umuo kasi gusto ko ang magsweldo sa akin private. Kasi pagkatapos ng BBM, kawawa naman ako. No? So, ang tawag doon loan. I-loan lang ako ng company namin. I will function as undersecretary, but I will not be the sweldo must not come from the government, ang sweldo sa private. Ginawa yon sa undersecretary panahon ni Gina Lopez. Hindi naman siya rocket science, hindi ko maintindihan mga lawyers, ba't di nakakaintindi ng loan? Ayoko na sisweldohan ako ng gobyerno kasi sa hangganan ni BBM nilang hangganan. Sayang naman yung aking sweldo sa private. Hindi naman sa ayaw ko. Kasi sa private, mas nauna, sorry mas nauna ako sa gobyerno. Odette, ang Air Force bago nakalipad, ako unang lumipad. Pumunta kami ng Turkey sa earthquake. Government nagpadala. Ang Morocco, walang government nagpadala. Andun ako. Private. Mas marami akong magagawa. Wala akong bureaucracy. Ayaw na ayaw ko, inuutusan ako sa bagay na kung saan doon ako magaling. Sorry with the word. Magaling ako sa disaster management. Magaling ako sa disaster medicine. This has been my life. Ang uutos sa akin ay hindi niya specialty. Mag-aaway talaga kami. So I don't like it. Ayoko yung may kaaway ako. Pero alam mo naman sa medisina, specialty-based. Disaster medicine, combat medicine, expedition medicine, akin yun. Kasi yun ang training ko. Hindi siya 4 years, maiksi lang siya. Marami akong exposure. Ngayon nga lang, hinihintay ko eh. Kung maganda lang, sorry kung maganda ang sweldo, nagulangan na kasi ako dati sa abroad eh. Kung maganda ang sweldo, I'll be in Gaza, Egypt as doctor. I'll spend my Christmas there. 1 month lang ako. Kung bibigyan ako ng $1,100 per day, kaya ko mag 1 month, I'll spend my Christmas there. Pero kung gugulangan nila ako sa sweldo, kasi maraming magulang diyan, mga handler. Si sweldo na ako 1,000 per day sa hostile environment. Ang natatanggap ko lang $600. Yung $400 sa handler ko, nakukuyakoy doon sa Dubai. Ayaw ko ng ganun siya, masarap buhay. Sabi ko, gusto kong makita ang money trail. Kasi akin ang gamit, mainly yung importante. Yung ibang gamit, mga IV, doon na kukuha ko. Walang problema. Pero yung mga sophisticated material, halimbawa, pag-intubate ko na di camera, akin yung personal ko yun. Capnometer, personal ko. I'll bring my own defibrillator. Ganun personal ko yun. Anyway, ang standard, nagpa-first aid tayo na hindi tugma sa pang-doktor. Doctor, nurse tayo. Hindi tayo pwede turuan ng first aid. Okay, sagutin ko to. Ang naloxone, binibigay lang siya kapag merong opioid overdose. Ano yung opioid? The likes of morphine, that's opium. Anything na may opium. Hindi covered sa Pilipinas, sabi ko kanina, dahil hindi can't afford. Kung ako addict, hindi ko afford si opium. Kaya nahulog lang tayo sa shabu. Okay? Si shabu hindi pwede pang naloxone. Sa naloxone si shabu. Si shabu, wash out lang talaga yan sa urine. Vitamin C lang yan, wash out mo yan sa urine. Ang naloxone is opioid. So, pag ang opioid, respiratory depressant yan. Nakakita na akong ganyan. Pag nagbigay ka, na-reverse niya. Meron ako mga tropa na isang ex-police, isang ex-FBI, ang experience nila sa hindi nag-arrest, pag nag-reverse ka ng naloxone, sasaksakin ka or barilin ka nila kasi maganda at tama ng drugs tapos biglang ni-reverse mo. So, ayaw nila yun. Dito naman sa atin, ang naloxone binibigay natin sa nagre-respiratory arrest and or cardiac arrest because of respiratory arrest. Kahit anong CPR, defibrillate mo yan, hindi mo mabubuhay yan hanggat hindi mo i-reverse yung naloxone. Ang naloxone natin is IV. Pag nagbigay kang IV, ACLS provider ka. Kawawa ka naman kung hindi ka ACLS provider. Kaya ginawa ang nasal spray para sa BLS provider. Okay? So, ang senaryo natin, nag-CPR ako, opium overdose, bigay ako ng nasal. Tapos defib, CPR, drug, shock, yeah. Compress shock, naloxone, compress shock, naloxone, compress shock, naloxone. Pero ang ideal, pag nagbigay ka ng naloxone, first drive, okay na yun. Pag second drive ka, you call the doctor. Doc, it's not yet reversed. Can I give another? Ang tawag doon, OLMC, Online Medical Control. Hindi uso sa Pilipinas, again, kasi wala tayong pre-hospital law. Yan. So, hindi ibig sabihin, pag nag-arrest ako na may naloxone. It's not the standard for arrest. Any question? May drugs ba? Yes. Oxygen. That's the only drug in BLS. Wala na. Tapos naloxone kung opium. Other than that, wala na. Oras nagbigay ka ng epinephrine, hindi ka na BLS, ALS ka na, ACLS na. Kasi epinephrine, wala kang pagbibigyan kundi intravenous or intraosseous. Once you use needle, mag-intravenous, pumasok ka na sa mundo ng advanced cardiovascular life support. Yan. Yun ang demarcation ng ACLS. Nag-ACLS ka kapag nagswero na, kasama siyempre, nagswero ka, may drugs. Pangalawa, nag-intraosseous ka sa buto, may drugs. Pangatlo, nag-advanced airway ka na supraglottic or endotracheal. Pero pag mamaya pa, ipapakitaan ko kayo ng basic to advanced. Basic lang, nasopharyngeal or oropharyngeal, basic. Pero pag naglagay na ako ng supraglottic or endotracheal tube, advanced airway na. Question? Hanggang tayo. Do we detect ECG reading sa BLS? Yes and no.
Mababasa mo yung mga chat, yung mga tanong.
Yun. So, doktor ako, gamit ako ng manual. Wala pa, walang cross cart, no nothing. Pero doktor ako, or nurse ako. Ang ginamit ko ay hindi AED. Ang ginamit ko ay manual defib. Marunong ako mag-manual defib. Dinefib ko siya, CPR. Okay, saglit. Walang susigaw analyzing kasi hindi naman AED. Manual. Pagtingin ko ngayon sa screen, oy, BF, okay, I'm going to shock the patient, ha? Charging to 200 joules. One and clear. Two year clear, clear. Three years clear, clear. Okay, shock, boom. BF pa rin, sige, tuloy lang CPR. Nasaan na yung cross cart natin? Yun, basic yun. Pero nanood ako ng ECG. Nakita ko ventricular fibrillation. Basic pa rin yun. Okay? As long na wala kang drugs beyond oxygen naloxone. Kung magbigay lang ako ng sugar, hindi ka pwede magbigay ng sugar sa arresting patient, pinapahid mo sa buccal mucosa. Hypoglycemia na level 1, dapat ang pasyente gising. Pinapahira natin ang EMT gumagawa, but not in arresting. Bawal maglagay anything sa arresting patient. Dadaan ko sa IV. Hindi na basic. Nag-IV ka na i-direct ko. Hindi na basic. Nag-direct line ka na intravenously. Advanced na yan. What else are basic pa? Ang basic requirement, okay, there are 3 courses na kailangan may BLS. Hindi ka pwedeng makakuha na hindi ka BLS provider. Number 1, ACLS. No way lulukso ka ng ACLS na wala kang BLS. Okay? Yan. 2, no way kang mag-pediatric advanced life support na wala kang BLS. 3, no way kang mag-neonatal resuscitation program from neonate kung wala kang BLS. Mandatory sa 3. Kailan siya hindi mandatory pero dapat BLS provider ka? Basic, the bare minimum. Advanced trauma. Anong silbi mo sa trauma na simpleng basic life support, pag compression, wala kang alam. Bawal yun. So BLS itself is a requirement. Okay ako in-institute ng gobyerno even to doctors and nurses. Kasi may nagkakamali pa amongst doctors and nurses sa compression, sa bag valve mask operation. Totoo yan. Ilang beses ko nakita colleagues ko mali paghawak sa bag valve. Kaya tayo nag-bag valve mask. Ang intention is to put air to the lungs, not to the stomach. You put air to the stomach, you will have a problem later. Pag bumaliktad yung stomach, mayroon niyang vomitus, patay. At pag yung vomitus pumunta sa lungs, aspiration, nako, prepare yourself to go to court. Kaya, pag nilunod, tuturuan ko kayo paano mag-CPR lunod. Nalunod to si mama. Bantayin niyo pag nalunod ang tao, usually, susuka yan. Most often susuka. Pag suka niya, gaganon, kusa siyang babangon konti at tatagilid. Kung malakas, kung hindi siya malakas, pag suka niya, gaganon siya, Pag hindi siya makatagilid, ang next episode niyan, hihigupin niya suka, mag-aspirate. Ikaw ngayon natutulong. So, ganito po ang recovery position. Mabilisan. Suka siya, wap, hatak agad. Huwag yung patagal-tagal. Kasi pag sa basic life support, ang recovery position ay ganito. Kung nabuhay mo na ang tao sa out of hospital, out of hospital. Turuan ko lang kayo, anong gagawin mo? Nakabuhay kayo ng tao out of hospital. Okay? Sinisipiyar ako. Sa out of hospital, kung nandito ang nagsisipiyar sa akin, ito yung iaangat niya na meron akong pulso. Angat. Bitawan niyo to. Bitawan niya. Hindi mo kailangan. Pangalawang iangat ito, ilagay dito. Dito ang hawak. Huwag bitawan kasi pag bitawan ang dead weight, mahuhulog yan. Tapos iangat ng kabilang kamay niya yung aking right knee. Right knee ko, tingnan nyo, right knee, nakaangat to. Mara-right knee at ito, itatagilid ako. Yan yung recovery position. Ito ay anong tawag sa Tagalog? It's like it's not an anchor. It serves as a support, a truss, TRUSS, para hindi masubsob ang mukha ko. Hindi masubsob. Yan. So, ang recovery position, ang forma ay ganito. Yan. Ito. Yan. Yan. Sa out of hospital. Para yung secretion ko, tatagas lang yan. Pag ako ay na-recover na. Return to spontaneous circulation. Or pag may seizure, pag after sa seizure, na presente, lie down, ganito rin, recovery position. Pag nakakita kayo, ganito ginawa ng tao, that guy is a professional responder. Huwag ganon, kasi susubsob ang mukha ko. Dito dapat, yan. Kaya ulitin ko, yan, taas kamay sa huwag. Kung papunta doon, kung papunta lang sa kabila, ito din isa. Yan din. Yan, taas punta sa kabila. For the sake sa camera, papunta ako doon. Okay? At, ito, hawakan ng kamay ito, hawakan ng kamay ito. Yan, ang recovery position. Okay? Question. If there's no question, I'll give you back to Ma'am Joy because you will have your exam. Ayan. And some videos, hindi siya American Heart 2020 interim guidelines, pero halos kami na nandun. There might be some structure, sundin niyo lang yung lecture ko kasi wala pa kaming bagong video. Hindi pa nag-release. Siyempre, mauna si ASI kami. Hintay pa kami ng overall release talaga, which is like a 2020. Okay? So, you will have exam, tapos while you watch the video to amalgamize the initial learning that you have. And for those who will take ACLS, I'll be seeing you 1 p.m. Prepare yourself for quite a intensive battle because there's really a challenge in virtual. Mas madali tapusin si virtual kaysa sa face-to-face. Kasi si face-to-face, ubos ako ng 3 araw kasama si ECG reading. Dito, halos sinikip siya lahat. Tapos, siyempre virtual, walang ganong return demo on certain things. Napaiksi. But I need you to be adult enough to imagine things because ACLS is quite tough. Okay? So, I wish you well in your exam. And see you 1 o'clock p.m. God bless you guys. If you have questions that's gonna pop out a bit later, send me message or SMS here kasi hindi ko papatayin to. And I'll humbly answer them. Okay? Ma'am Joy, endorsing to you.
Thank you so much po, Doc. Hello po. For your BLS exam po, I'll be sending the exam link po at the meeting group chat po. Yan po. Nasend ko na po sa meeting chat yung exam po for BLS. You can take your exam na po. Then may ipi-play po akong mga videos. You can watch it po while taking your exam. Thank you po.
Basic Life Support, or BLS, is emergency medical care provided by first responders, healthcare providers, and public safety professionals to persons experiencing respiratory or cardiac arrest or an obstructed airway. It requires knowledge and proficiency in cardiopulmonary resuscitation, or CPR, use of automated external defibrillators, or AEDs, and techniques to relieve airway obstruction in patients of every age. This BLS training program is intended for healthcare providers and other public safety professionals working in a wide variety of occupational settings, in and out of hospital, and individuals enrolled in healthcare and public safety career courses. The purpose of this BLS training program is for participants to gain or improve knowledge and skill proficiency in high-quality CPR skills for the adult, child, and infant. This training program will allow you, the BLS provider, to learn and practice skills according to your experience and in the context of your setting, utilizing different practice methods such as video-guided and scenario practices. Cardiac arrest is the loss of the heart's ability to pump blood through the body due to inadequate or absent cardiac function. The most dramatic occurrence, sudden cardiac arrest, or SCA, can happen anywhere with little or no warning.
It was a beautiful, sunny, warm July 31st, and Lynn, my wife, and I had gone grocery shopping.
It was otherwise kind of a typical summer day.
We were unloading the groceries. Lynn and I schlepped some in, and then I went out to get the rest.
We can tell by retracing my steps that I had put some things in the pantry and was headed back out to the car, but I never made it because I went down.
Was only gone about 60 seconds. In that small amount of time, my world changed. I turned her over on her back, and her face was turning blue, and I heard these sounds like she was trying to breathe. Sound like she was gasping for air, and it's a sound you just don't want to hear your wife have. You just don't want to hear that sound.
Hello? Hi, I need an ambulance right away.
At what address?
I dialed 911 right away, and I put the phone down next to her and proceeded with the chest compressions and the breaths.
It's my wife. She's turning blue. She's turning blue. I gotta give her CPR.
Is she breathing?
No.
Okay, lay her flat on the ground with nothing under her head. Do you know how to do CPR?
Yes, a little bit. Okay, I'm pushing.
When the call came in and we heard the information, it was a cardiac arrest. If I knew that the crew was not here, they were out training at another station. Knowing it was a cardiac arrest and the importance of getting there quickly and starting care, myself and the battalion chief made the decision to respond to that.
Is your door unlocked?
Yes, I'm right.
Many minutes went by while I was administering CPR before I heard sirens outside.
I entered through the front door and I was able to see CPR being performed in the living room.
I found her laying on the floor.
Quickly encouraged the husband to continue doing CPR and push hard and push fast on the chest.
Saw her go down? No, I found her. He was loading groceries from the car into the house. She was helping load them, and then I found her just like this. Please check the pulse. Keep going, push hard, push hard.
These last moments of my opportunity to give CPR, and that's how I regarded it, was a great opportunity to actually participate in the rescue. My neighbor, who's a physician's assistant, heard the sirens and she came over to see what was going on.
As I was putting the AED on, the patches, the neighbor identified herself as medically trained.
Yeah, you know CPR? No, I'm a PA. Hey, go.
I asked her to go ahead and to relieve the husband from doing chest compressions at that point and had her start performing CPR.
So she hopped in there to take over because I was kind of freaking out. I mean, right now, even thinking about it is really bringing back the memories. It was terrifying. I felt helpless. I mean, it was now all in their hands. I had done all I could do.
Analyzing heart rhythm.
After analyzing the rhythm of the patient, the AED identified that it was a shockable rhythm, and we delivered a one shock. At that point, I went ahead and took over CPR compressions, and Annie started giving airway assist. And after giving CPR for about a minute, I noticed Lynn starting to make noises with my chest compressions.
I asked him, do you have a pulse? And he said, yes, we have a pulse. And I tell you, that was a beautiful sound to hear that.
So we stopped doing chest compressions and we continued breathing for her. That's when the crew, the paramedics, and the firefighters were coming through the front door. And I was able to then step back and give a report to the lead medic that was coming in and that was gonna do the transport.
And they got my heart started again, loaded me onto the gurney and rushed me to Corvallis Samaritan Regional Medical Center, where they continued to save my life. When I woke up, they had put posters on the wall in front of me. And it was very orienting. It said, Kent called 911, did CPR. He saved your life. You're at Corvallis Good Samaritan Regional Medical Center.
The CPR being performed by the husband was huge. I'm sure it was probably 2 to 3 minutes. And during that time, if CPR wasn't being performed, that's 2 or 3 minutes that she's not receiving blood. A lot of things went right for this call and for Lynn, the chain of survival.
So it was a team effort, a chain, and that includes our dear neighbor, Annie.
Learning CPR, knowing how to do it, and then actually doing it are really important because you can literally save somebody's life.
BLS providers play a key role in the resuscitation effort following cardiac arrest, both out of hospital and in hospital or clinic settings. By training and practicing, BLS providers can help ensure the links in the chain of survival are strong in any setting for every patient. In order to clearly demonstrate high-quality skills, BLS providers in this training program may not always be shown wearing appropriate personal protective equipment. Local medical protocols are emergency medical service treatment guidelines approved by the local EMS medical director. Local protocols outline the permissible medical treatments that may be given by EMS providers outside the hospital to patients experiencing a medical emergency. EMS providers should always follow their local physician-directed medical protocols.
so sweet. I'm kidding. Marcus, you need to come here, move to Eugene, go to the University.
Think about dropping out.
Sudden cardiac arrest occurs when the normal electrical impulses in the heart cause it to beat too quickly, inefficiently, or in an unsynchronized manner. When the lower chambers of the heart beat too quickly or quiver, the heart cannot pump blood. These abnormal heart rhythms, or dysrhythmias, are known as pulseless ventricular tachycardia and ventricular fibrillation. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen. A victim of SCA may suddenly collapse.
Grandpa, hey, stay with me. Hey, I need some help. Grandpa, stay with me. Grandpa, don't.
What's going on? Is he okay?
I don't know, he just fell out. I need you to call
Occasionally,
911, please.
SCA victims will experience 10 to 20 seconds of seizure activity when the brain
Hey, I need
stops
some help.
receiving oxygen.
Hey, I need some help.
Normal breathing stops. Abnormal gasping may last for several
I have no
minutes.
clue what happened till he just fell down.
Okay. Let's go. That's back. Can you hear me? Sir, can you hear me? I have one person down in the main lobby. He's unresponsive. Start me 911 and get an AED. We'll start CPR. He's not breathing. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
CPR is the immediate treatment for suspected SCA. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions, an open airway, and rescue breaths. However, CPR alone is not enough. The most effective way to end pulseless ventricular tachycardia and ventricular fibrillation is defibrillation.
Remove clothes from patient's chest.
Using a defibrillator and electropads adhered to the chest. An electrical shock passed through the chest can restore the heart's normal contractions.
Analyzing heart rhythm. Stay clear of patient.
Immediate, high-quality CPR and early defibrillation with an AED can more than double the likelihood for survival. These two elements are parts of the adult chain of survival, a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 adult chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of early recognition of cardiac arrest and prompt activation of EMS, immediate high-quality CPR beginning with chest compressions, early defibrillation with an AED when indicated, effective advanced life support treatment, effective post-cardiac arrest care at a hospital, and recovery. The adult out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest, prompt activation of the emergency action plan and response by teams of medical professionals, immediate high-quality CPR beginning with chest compressions, prompt defibrillation when indicated, effective post-cardiac arrest care, and recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. The majority of cardiac arrests happen at home or in the workplace. Early recognition of SCA and activation of EMS or an emergency action plan gets help coming right away. Immediate high-quality CPR improves the victim's chance of survival by providing oxygen to the heart and brain. After activating EMS, an untrained layperson should provide chest compression-only CPR, ideally with their phone on speaker mode and with the assistance of an EMS dispatcher. Attaching an AED as soon as it becomes available speeds up the time to defibrillation if indicated. Effective advanced life support treatment with a focus on return of spontaneous circulation, or ROSC, and transport to a hospital for all patients with a chance of survival supports the most favorable outcome. Effective post-cardiac care, including monitoring and the use of medication, helps prevent the return of cardiac arrest and improves the likelihood of long-term survival. Recovery supports the patient's physical and emotional needs that are ongoing after hospital discharge.
BLS providers should follow the adult BLS procedure, a step-by-step guide for responding to a potential adult cardiac arrest. The adult BLS procedure is a process composed of tasks that can be performed in a step-by-step manner by a single BLS provider or performed simultaneously by multiple providers working as a team. There are three main elements of the adult BLS procedure: assessment of the scene and patient, actions based on presence or absence of normal breathing and a pulse, and use of an AED. As a single BLS provider, upon arrival and before anything else, pause to make sure the scene is safe for you and the victim. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. This includes taking standard precautions. In this program, take standard precautions means use appropriate personal protective equipment, or PPE, to protect against possible exposure to infectious agents. Appropriate PPE may include gloves, goggles or face shields, surgical masks, gowns, respirators, CPR masks, and bag mask devices. Experience putting on and taking off PPE, also called donning and doffing, is critical for your safety and to minimize potential delays in emergency treatment. Train and practice according to local medical protocol or your healthcare facility's established PPE procedures. If the scene is safe, assess responsiveness. Tap the victim and ask loudly,
"Sir, sir, are you okay?"
If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. After activating, get an AED and your emergency response equipment, or if someone else is available, send them to get it. Simultaneously assess breathing and the carotid pulse. Place 2 or 3 fingers in the groove on the patient's neck, between the trachea and the muscles at the side of the neck. Look at the patient's chest and face for signs of normal breathing. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, snoring, or gurgling sounds are known as agonal breaths. This is not normal breathing. It is a sign of cardiac arrest. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then, take action based on the presence or absence of normal breathing and pulse. If the pulse is not felt and the unresponsive patient is not breathing normally, or only gasping, immediately start CPR, beginning with chest compressions.
1, 2, 3, 4, 5, 6, 7, 8.
If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway.
High-quality CPR is the primary influence on survival from cardiac arrest. High-quality chest compressions are the foundation of high-quality CPR. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. When chest compressions stop, blood flow decreases significantly. When compressions start again, it takes several compressions to restore blood flow. The more times chest compressions are interrupted and the longer the interruption, the less the blood flow to the brain, heart, and other organs. Minimal interruption improves blood flow. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, immediately start CPR, beginning with chest compressions. CPR should be performed where a victim is found as long as it is safe to do so. To deliver adult chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. Place the heel of one hand on the center of the chest, on the lower half of the breastbone. Place the heel of the other hand on top of and parallel to the first. Interlock your fingers if necessary to keep them off the chest. Alternatively, you can place one hand on the center of the chest and use your other hand to grasp your wrist for support. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Push hard and deep, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. Chest compressions are most often performed too shallowly. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position, but do not lose contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Push fast. Compress the chest at a rate of 100 to 120 compressions per minute. CPR feedback devices transmit information on compression rate, depth, and recoil. Providers can significantly improve chest compression quality by adjusting technique based on data from a feedback device. Using a CPR feedback device is shown to improve patient outcomes and is recommended during CPR training and in real-life resuscitation attempts, both in and out of hospital. Fewer and shorter interruptions in chest compressions are associated with better outcomes. Time spent during a resuscitation attempt without chest compression, called hands-off time, should be kept as short as possible. Chest compression fraction, or CCF, is the proportion of time that chest compressions are performed during a cardiac arrest resuscitation effort. Higher CCF percentages are associated with high-quality CPR and greater rates of survival. A CCF of at least 60% is recommended, but higher percentages are desirable and achievable.
Rescue breathing is an artificial ventilation of the lungs. It provides oxygenation of the blood and removal of carbon dioxide. It is an important component for successful resuscitation. Conventional CPR with rescue breathing should be performed by all BLS providers, both in and outside the hospital. To give rescue breaths, there must be an open airway. The airway is the only path for getting air into the lungs. When an unresponsive patient is lying flat on their back, decreased muscle tone and the pull of gravity causes the back of the tongue to obstruct the upper airway. The tongue is connected to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat, relieving the obstruction and opening the airway. Two methods to open the airway are the head tilt chin lift and the jaw thrust. Use the head tilt chin lift maneuver to open the airway of a patient when head or neck injury is not suspected. To open the airway with a head tilt chin lift maneuver, position yourself at the patient's side. Place one hand on their forehead. Place the fingertips of your other hand under the bony part of the lower jaw, near the chin. Apply firm backward pressure on the forehead while lifting the chin upward. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Leave the mouth slightly open. If the BLS provider suspects a spinal injury, open the airway using a jaw thrust without head tilt. To open the airway with a jaw thrust, position yourself at the patient's head. Place one hand on each side of the patient's head. Place your fingertips under the angle of the lower jaw and lift it upwards until the lower teeth are higher than the upper teeth. If the patient's lips close, use your thumbs to push the lower lip open. An open airway is a higher priority than protecting a possible spinal injury. If the jaw thrust does not open the airway, use the head tilt chin lift maneuver. Both the head tilt chin lift and jaw thrust maneuvers should be performed correctly and quickly to minimize interruptions in chest compressions.
Rescue breaths are critically important in BLS care, as they provide life-sustaining oxygen and ventilation directly to the patient's lungs. In addition to SCA patients, BLS providers are likely to provide care for victims of respiratory arrest and secondary cardiac arrest, for whom effective rescue breaths are essential. Rescue breaths are given by blowing the BLS provider's exhaled air into the valve of a CPR mask, or by pushing air into the lungs through the airway using a bag mask device. Gasping in SCA is common but is not normal breathing. If the pulse is not felt and the unresponsive patient is not breathing or is gasping, immediately start CPR, beginning with high-quality chest compressions. After 30 compressions, open the airway and give 2 rescue breaths. Perform cycles of 30 chest compressions and 2 rescue breaths. In respiratory arrest, breathing has stopped, but the heart continues to beat. This is a life-threatening medical emergency caused by diseases such as pneumonia or other conditions such as stroke, choking, drowning, and drug or alcohol overdose. If rescue breathing is not provided during respiratory arrest, the patient's heart will stop within minutes. This is secondary cardiac arrest. If the pulse is definitely felt, but the unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give 1 breath every 6 seconds or 10 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. Check the pulse about every 2 minutes. If the pulse is not felt and the unresponsive patient is still not breathing, immediately start CPR. Excessive ventilation, too many breaths or breaths that are too large, can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Air in the stomach can also cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the patient's chest rise, but no more than that. Take standard precautions when providing adult rescue breaths. Use a CPR mask or bag mask device in addition to other appropriate PPE. Some CPR masks and bag mask devices allow you to attach a high-efficiency particulate air, or HEPA, filter to provide further protection during CPR. The HEPA filter fits between the valve and mask, in the path of the patient's exhaled gas. HEPA filters can trap airborne virus particles. BLS providers can give rescue breathing using their own exhaled breath and a CPR mask. Room air contains about 21% oxygen. exhaled air contains between 16 and 17% oxygen. This exhaled oxygen is enough to support life. To use a CPR mask, position yourself at the patient's side. Place the mask flat on the person's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your other hand, lifting the chin, to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with the head tilt chin lift maneuver. Lift the patient's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of the chest, but no more. Stop ventilating as soon as you see the chest rise. Remove your mouth and let the patient exhale. A bag mask is a handheld device used to inflate the lungs. The device consists of a bag attached to a face mask. BLS providers can give rescue breathing using a bag mask and room air. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. To use a bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use the remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise.
An automated external defibrillator, or AED, is a portable computerized device that is simple to operate. It can identify pulseless ventricular tachycardia and ventricular fibrillation and deliver an electric shock to restore the heart's normal contractions. If the electric shock is effective, there will be a return to spontaneous circulation, or ROSC. The heart will be able to pump blood, and the patient will have a pulse that can be felt by the BLS provider. The patient may also start breathing, moving, or reacting in other ways. If you have an AED in your workplace, be familiar with its operation. AED design varies by model and manufacturer, but they all operate in a similar manner. Proper AED operation requires direct contact between the pads and the patient's skin. Any clothing in the way must be removed. This includes swimsuits, bras, and any other clothing covering a patient's chest. If necessary, cut through clothing with the shears that are typically included with a CPR and AED response kit. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice prompts and readies the device for use.
Plug in pads connector.
Use adult AED pads for patients 8 years or older. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each according to the pictures. Press the pads firmly in place. Avoid placing pads over medication patches or implanted devices. Try to apply the pads within 30 seconds after the AED arrives. When the AED voice prompts you,
do not touch patient.
Clear the patient. Be certain that no one is touching the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If the AED advises a shock, it will prompt you to clear the patient again.
Clear. Press flashing button.
If directed by the AED, deliver a shock.
Shock delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR, the AED will prompt you again to analyze the heart rhythm. Follow the voice prompts.
Do not touch patient.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
Anna. I don't know. I walked in the kitchen and my best friend's on the ground.
Every adult resuscitation attempt is different in terms of setting, circumstance, and available resources.
You have to help her. She's right here.
While working as a coordinated team is common, BLS providers also need to be able to provide high-quality CPR as a single provider.
Are you okay? Code 3, send medic.
If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, one BLS provider can provide high-quality adult CPR by putting together all the skills of assessment, compressions, airway, breathing, and AED use.
Do not touch patient. Analyzing heart rhythm. Everyone clear. Press
Stand clear, stand clear. All right, shocking.
Shock delivered. Provide chest compression.
First, assess scene safety and take standard precautions. If the scene is safe, assess the patient's responsiveness. If the patient is unresponsive, activate EMS or your occupational emergency action plan. Get an AED and emergency response equipment or send someone else to. Assess the patient's breathing and carotid pulse at the same time for no more than 10 seconds. If the patient is not breathing normally or only gasping, and you do not feel a pulse, start high-quality CPR. Position the patient on a firm, flat surface. Position 2 hands on the lower half of the breastbone. Compress at least 2 inches or 5 centimeters. Use upper body weight to compress. Compress at a rate of 100 to 120 times per minute. Allow the chest to fully recoil at the top of each compression. Use a CPR mask or bag mask device. Open the airway and give 2 rescue breaths. Ensure each breath is 1 second in length and creates visible rise of the chest. Immediately resume high-quality chest compressions. Repeat CPR cycles of 30 compressions and 2 breaths for 2 minutes. As soon as an AED is available, power on the AED.
Remove all clothing
Bare
from
the
patient's
chest. Correctly apply the AED pads.
Pull red handle to reveal pads. Do not
Make sure no one is touching the patient. If directed by the AED, deliver a shock. Immediately resume CPR starting with chest compressions. Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways.
James?
Oh, you know, kids.
James?
Doing it in
Are you
preschool,
out here? James? James? James! James! Oh no! No! Somebody help! Somebody help me! James! James! James, honey! James!
What happened?
I don't think he's
breathing.
I'll calm down. Calm. All right, help me get him to the ground.
Okay.
All right,
James.
come on. Gently, gently. All right, gently. Okay, come on.
Hello. Yes.
All right, watch out.
We had a kid drown in the hot tub.
James. James, can you hear me?
Sudden cardiac arrest in children is not typical, but it can and does occur in children of all ages. More often, though, cardiac arrest in a child results from asphyxia, a lack of oxygen caused by respiratory failure or respiratory arrest. When breathing slows or stops, it leads to bradycardia, a slow heart rhythm of fewer than 60 beats per minute. At that rate, the heart is not able to pump enough oxygen-rich blood to the body. The lack of oxygen causes the heart to stop within minutes. Causes of respiratory failure or respiratory arrest and subsequent cardiac arrest include airway obstruction, lung infections or diseases, drowning, choking, and shock resulting from injuries, such as motor vehicle accidents, burns, falls, and child abuse. Prevention is critical in reducing pediatric cardiac arrest deaths. In the out-of-hospital setting, prevention includes the use of essential safety equipment, such as child passenger safety seats and bicycle helmets, and proper supervision. In the hospital, cardiac arrest prevention focuses on early recognition and treatment of at-risk children. In this BLS class, a child is defined as 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. For those with signs of puberty, provide adult BLS. Like the adult chain of survival, the pediatric chain of survival consists of a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 pediatric chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of prevention of causes of cardiac arrest, respiratory failure or respiratory arrest, prompt activation of EMS, immediate high-quality CPR and defibrillation, advanced resuscitation, effective post-cardiac arrest care at a hospital, and recovery. The pediatric out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest. Prompt activation of the emergency action plan and response by teams of medical professionals. Immediate high-quality CPR and defibrillation. Advanced resuscitation. Effective post-cardiac arrest care. And recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. BLS providers should follow the procedure for pediatric BLS, a step-by-step guide for responding to a potential cardiac arrest. Using this procedure, you can perform child BLS as a single provider and as a member of a team. Like the adult procedure, there are three main elements of the pediatric BLS procedure: assessments of the scene and patient, actions based on presence or absence of normal breathing and a pulse, and use of an AED. First, assess scene safety. Upon arrival and before anything else, pause to make sure the scene is safe for you and the victim. This includes taking standard precautions. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. If the scene is safe, assess responsiveness. Tap the victim and ask loudly,
"Are you okay?"
If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Simultaneously assess breathing and pulse. Look at the patient's chest and face for signs of normal breathing. Weak, irregular gasping, snorting, snoring, or gurgling is not normal breathing. It is a sign of cardiac arrest. At the same time as assessing breathing, check the child's carotid or femoral pulse. To locate the carotid pulse, use the same technique as you would on an adult. To locate the femoral pulse, place 2 or 3 fingers midway between the hip bone and the pubic bone, just below the crease where the leg joins the torso. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on the presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly reassess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Perfusion is the circulation of oxygenated blood through tissues. The signs of poor perfusion include pale, mottled, or blue lips or skin, decreasing responsiveness, weak pulse, cool extremities, particularly the hands and feet. Poor perfusion is an indication that cardiac arrest is imminent. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. Beginning CPR prior to full cardiac arrest can improve likelihood of survival. If the pulse is not felt and the unresponsive pediatric patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. A witnessed cardiac arrest is one that is seen or heard, or an arrest that occurs when the patient is connected to a heart monitor. If the sudden collapse of a child was witnessed, you may assume that the child has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Activate EMS or your facility's occupational emergency action plan if you haven't done so already. Quickly return to the patient, use the AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in children is most frequently caused by asphyxia, about 2 minutes of CPR is recommended before leaving the child to get an AED and activate EMS. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival.
As in the adult procedure, high-quality chest compressions are the foundation of high-quality CPR. To deliver child chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. For child compressions, place 1 or 2 hands on the center of the chest. For a small child, 1 hand may be enough. For most children, The compression technique is the same as for the adult. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Whether you use 1 or 2 hands, push hard, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position without losing contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruption in chest compressions.
As with an adult, there must be an open airway to give rescue breaths to a child. The two methods to open the airway are the same: head tilt, chin lift, and jaw thrust. Use the head tilt, chin lift maneuver to open the airway of a child when head or neck injury is not suspected. Rescue breaths are extremely important for children because cardiac arrest typically results from asphyxia. If the pulse is definitely felt, but an unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give 1 breath every 2 to 3 seconds, or 20 to 30 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Excessive ventilation, too many breaths, or breaths that are too large can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Take standard precautions when providing child rescue breaths. Use a pediatric CPR mask or bag mask device in addition to other appropriate PPE. Use a child-sized mask as you would for an adult. Position yourself at the patient's side. Place the mask flat on the child's face, with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Tilt the head and lift the chin to open the airway. Lift the child's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. Pediatric bag mask devices are available in child and infant sizes. Select a child-sized bag mask. To use a pediatric bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise. Check the pulse every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR.
Most AEDs are designed for both adult and pediatric use. The energy level of the shock for pediatric use is reduced from the standard adult energy setting. The shock is reduced by an electronic device called an attenuator, which frequently comes with pre-connected pediatric pads. The attenuator may also be built into the AED and activated using a button, key, or another type of switching mechanism. Pediatric pads are recommended for children below 8 years of age. If the child pads are not available, use the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Do not apply child pads to patients 8 years of age and older because the energy level of the shock will be too low. Turn on the AED and bare the patient's chest.
Remove all clothing from patient's.
If there is a button, key, or another type of mechanism for switching to child use, activate it.
Child mode.
Peel the pads from the backing sheet one at a time and place each according to the pictures. Some pads require a front and back position. Others require a left-right position. Press the pads firmly in place. Do not allow them to touch each other. When the AED voice prompts you,
Do not touch patient.
clear the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If directed by the AED,
Everyone clear.
be certain that no one is touching the patient.
Press flashing button.
Deliver a shock. Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR,
Do not touch patient.
the AED will prompt you again to analyze the heart rhythm.
Analyzing heart rhythm.
Follow the voice prompts.
Press flashing button. Shock delivered.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
While working as a coordinated team is common, BLS providers also need to be able to provide high-quality child CPR as a single provider by putting together all the skills of assessment, compressions, airway, breathing, and AED use. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, one BLS provider can provide high-quality child CPR. First, assess scene safety and take standard precautions. If the scene is safe, assess the patient's responsiveness. If the patient is unresponsive, call 911 to activate EMS using a mobile device, or activate your facility's emergency action plan. Assess the patient's breathing and carotid or femoral pulse at the same time for no more than 10 seconds. For witness sudden collapse, if you are alone and an AED is nearby, get the AED. Activate EMS or your facility's occupational emergency action plan if you haven't done so already. Quickly return to the patient, use the AED, and perform CPR. For unwitnessed arrest, if you are alone, immediately start CPR, beginning with chest compressions. Perform 2 minutes of CPR before leaving the child to activate EMS or your facility's occupational emergency action plan and get an AED. Position the patient on a firm, flat surface. Perform 30 high-quality chest compressions. Position 1 or 2 hands on the lower half of the breastbone. Use upper body weight to compress. Compress at least 2 inches or 5 centimeters. Compress at a rate of 100 to 120 times per minute. Allow the chest to fully recoil at the top of each compression. Use a CPR mask or pediatric bag mask device. Open the airway and give 2 rescue breaths. Ensure each breath is 1 second in length and creates visible rise of the chest. Immediately resume high-quality chest compressions. Repeat CPR cycles of 30 compressions and 2 breaths for 2 minutes. As soon as an AED is available, power on the AED, bare the chest. If there is a button, key, or another type of mechanism for switching to child use, activate it. Use pediatric pads for children below 8 years of age. Correctly apply the AED pads according to the pictures. If the child pads are not available, use the adult pads.
Do not touch patient.
When the AED voice prompts you, clear the patient. If the AED advises a shock, the AED will prompt you to clear the patient again. Make sure no one is touching the patient. Deliver a shock.
Shock delivered.
Once a shock has been delivered, immediately resume CPR starting with chest compressions. Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. In BLS, an infant is defined as younger than 1 year of age, excluding newly born infants. Like the child BLS procedure, there are 3 main elements of the infant BLS procedure: assessment of the scene and patient, actions based on the presence or absence of normal breathing and pulse, and use of an AED. First, assess scene safety. This includes taking standard precautions. If the scene is safe, assess responsiveness. Gently tap the victim and ask loudly,
Are you okay?
if the infant is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. If you don't have a mobile phone nearby, bring the infant with you to activate. Simultaneously assess breathing and pulse. Check the infant's brachial pulse. Place 2 or 3 fingers on the inside of the upper arm, midway between the elbow and shoulder. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly assess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. If the sudden collapse of an infant was witnessed, you may assume that the infant has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Quickly return to the patient, use an AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in infants is most frequently caused by asphyxia, 2 minutes of CPR is recommended before activating EMS or your facility's emergency action plan if you haven't done so already. As with the adult and child, there must be an open airway to give rescue breaths to an infant. The 2 methods to open the airway are the same: head tilt chin lift and jaw thrust. Use the head tilt chin lift maneuver to open the airway of an infant when head or neck injury is not suspected. Keep an infant's head in a neutral sniffing position. Tilting the head beyond a neutral position that results in hyperflexion or hyperextension may block the airway. Rescue breaths are extremely important for infants because infant cardiac arrest typically results from asphyxia. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Air in the stomach can cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the infant's chest rise, but no more than that. Stop ventilating as soon as you see chest rise. Take standard precautions when providing infant rescue breaths. Use an infant CPR mask or bag mask device in addition to other appropriate PPE. Use an infant-sized pocket mask in the same manner as you would for an adult or child. Position yourself at the patient's side. Place the mask flat on the infant's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with a head tilt chin lift maneuver. Tilt the head and lift the chin to open the airway. Maintain a neutral sniffing position. Lift the infant's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. To use an infant bag mask device as a single provider, select an infant-sized bag mask device. Position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger of one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Maintain a neutral sniffing position. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Check the pulse about every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, or there is no pulse, start high-quality CPR. There may be a rare or extraordinary circumstance when a barrier device is not available, and a BLS provider is willing to provide artificial ventilation without a barrier. For infants, the preferred technique is mouth-to-mouth and nose rescue breathing. To give mouth-to-mouth and nose rescue breathing to an infant, open the airway with a head tilt chin lift. Take a regular-sized breath and place your mouth over the infant's mouth and nose, creating an airtight seal. Give 1 breath over 1 second. Give enough air to make the chest visibly rise, but no more than that. If the chest does not rise, repeat the head tilt chin lift, make a better seal, and try again. It may be necessary to move the infant's head through a range of positions to provide effective rescue breathing. If you have difficulty making an effective seal over the mouth and nose, try using the mouth-to-mouth technique.
As in the adult and child procedure, high-quality chest compressions are the foundation of high-quality infant CPR. To deliver infant chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. For infant compressions, use one of 3 hand position techniques: the 2-finger, 2-thumb encircling hands, or the heel of one hand. For the 2-finger technique, Place 2 fingertips in the center of the infant's chest, just below the nipple line on the lower half of the breastbone. Do not press the tip of the breastbone. Use both fingers to compress the chest. For the 2-thumb encircling technique, place the pads of both thumbs side by side in the center of the infant's chest, on the lower half of the breastbone. Your thumbs may overlap on very small infants. With the fingers of both hands, encircle the infant's chest and support the back. Use both thumbs to compress the chest. For the heel of one hand technique, place the heel of one hand on the center of the chest, on the lower half of the breastbone. Position your shoulder directly above your hand and straighten your arm to lock your elbow. Use the heel of one hand to compress the chest. This technique may be useful for larger infants, or when the BLS provider has difficulty compressing to the appropriate depth using fingers or thumbs. Whichever technique you use, push hard, straight down, compress the chest approximately 1 1/2 inches or 4 centimeters. This depth should be at least 1/3 of the diameter of the infant's chest. At the end of each compression, allow complete chest recoil. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruptions. Pediatric pads are recommended when choosing AED pads for an infant. If pediatric pads are not available, choose the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Turn on the AED and bare the patient's chest. If there is a button, key, or another type of mechanism for switching to pediatric use, activate it. Peel the pads from the backing sheet one at a time and place each according to the pictures. The front and back pad position is common for infants. Press the pads firmly in place. Make sure the pads do not overlap or touch each other.
Not touch patient. Analyzing
When the
heart
AED
rhythm.
voice prompts you, make sure no one is touching the patient.
Everyone clear.
If
Press
directed by the
flashing
AED,
button.
deliver a shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. Assess the scene for safety, regardless of whether you are first on the scene, and take standard precautions. If the scene is safe and you are the first BLS provider to reach the patient's side, assess responsiveness. As second BLS provider, activate EMS or the Emergency Action Plan and get the AED and emergency response equipment if available. Assess the patient's breathing and brachial pulse at the same time for no more than 10 seconds. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain the airway. Activate EMS or your facility's emergency action plan if you haven't done so already. To help protect the airway, place an uninjured infant in the recovery position. Lie the infant face down on your forearm. Support the infant's head with your hand. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt, but the unresponsive patient is not breathing normally, activate EMS or your facility's emergency action plan if you haven't done so already. With 2 or more BLS providers and appropriate equipment on hand, each provider takes a role to deliver effective ventilation using an infant-sized pediatric bag mask device. Position one BLS provider above the patient's head in charge of opening the airway and securing the mask with 2 hands. Position a second BLS provider on the patient's side to squeeze the bag. As BLS provider 2, deliver a rescue breath by squeezing the bag. Give 1 breath every 2 to 3 seconds, or 20 to 30 breaths per minute. Deliver each breath over 1 second in length while watching for chest rise. Give enough air to make the infant's chest rise, but no more than that. Stop ventilating as soon as you see the chest rise. Regularly assess the patient's responsiveness, airway, breathing, and pulse about every 2 minutes. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, the first BLS provider should immediately start high-quality CPR, beginning with chest compressions. The second provider should activate EMS or the facility's emergency action plan if you haven't done so already. When 2 or more BLS providers attempt to resuscitate an infant, use a compression to ventilation ratio of 15 compressions to 2 rescue breaths. Compress fast at a rate of 100 to 120 times per minute. Compress the chest approximately 1 1/2 inches or 4 centimeters. Allow the chest to fully recoil at the top of each compression. After 15 compressions have been given, the second BLS provider should open the airway and give 2 effective rescue breaths using a pediatric bag mask. Keep the infant's head in a neutral sniffing position. Repeat cycles of 15 compressions and 2 effective rescue breaths. Switch the person in the compressor's position frequently, about every 2 minutes. Try to minimize interruptions to compressions to less than 10 seconds. As soon as an AED is available, power on the AED. Bare the chest. If there is a button, key, or another type of mechanism for switching to pediatric use, activate it. Correctly apply the AED pads according to the pictures. When the AED voice prompts you, clear the patient. Make sure no one is touching the patient.
Analyzing heart rhythm.
If the AED advises a shock, clear the patient and deliver the shock. Once a shock has been delivered, immediately resume CPR, starting with chest compressions. If the AED does not advise a shock, immediately resume with chest compressions. Follow the AED's voice prompts. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways.
Choking, also known as foreign body airway obstruction, can occur when a solid object, such as a piece of food or a small object, becomes stuck in the upper airway. The person cannot breathe. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop out the obstruction. Chest compressions can also create enough pressure to expel a foreign body airway obstruction.
I'm exhausted.
To provide the appropriate care, you must be able to recognize the difference between a mild and a severe airway obstruction. With a mild obstruction, the patient can speak and cough. They may wheeze between coughs. A mild obstruction is typically cleared naturally by the patient through forceful coughing.
Cough it out. Come on.
If the person can inhale and exhale, encourage the patient to continue coughing. Watch for signs of the airway obstruction becoming severe.
That was scary.
Morning, Chrissy. How are you feeling?
Much better.
I need to get another set of your vital signs.
When a severe airway obstruction occurs, the patient cannot get air in or out of the lungs.
Are you choking?
This is a life-threatening medical emergency. If the foreign body is not removed, the patient will quickly become unresponsive and suffer a secondary cardiac arrest within minutes. Signs of a severe airway obstruction include the inability to speak, a weak cough, or no cough at all. The patient may make a high-pitched noise when trying to inhale or make no sound at all. They may hold their hands to the throat.
Try and get a breath.
If the patient is an adult or child, ask, "Are you choking?" If the person nods yes or is unable to speak or cough, act quickly. If you are not alone, have someone use a mobile device to call 911 to activate EMS or activate your facility's emergency action plan. Stand behind the patient. If needed, kneel behind a child. Reach around and locate the navel. Make a fist with the other hand and place it thumb side against the abdomen, just above the navel and below the ribs. Grasp your fist with the other hand. Quickly thrust inward and upward into the abdomen. Repeat. Each thrust needs to be given with the intent of dislodging and expelling the object. Continue until the patient can breathe normally or becomes unresponsive. If the object is expelled and there is good air exchange, encourage the patient to be seen by a healthcare professional. Infrequent but serious complications from abdominal thrusts can occur. If the patient becomes unresponsive, carefully lower the patient to the ground. Begin CPR starting with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the patient's mouth wide. If you see an object, remove it with your fingers. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If an infant appears to be choking but is responsive, watch for signs of the obstruction becoming severe. If there is good air exchange with a mild airway obstruction, the infant is coughing forcefully, has a strong cry, and can inhale and exhale, stand ready to help if things get worse. With a severe airway obstruction, the infant may cough weakly, be unable to cry, or unable to make any sound at all. There may be a high-pitched noise when the patient tries to inhale. If the infant is responsive and you are not alone, have someone call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Kneel or sit with the infant in your lap. Hold the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Rest your forearm on your lap or thigh to support the infant. Using the heel of the other hand, give up to 5 back slaps between the shoulder blades. Give each back slap forcefully with the intent of dislodging and expelling the object. Sandwich the patient between your forearms and turn the infant over, using the palm of one hand to support the face and the palm of the other hand to support the back of the head. Place 2 fingers on the breastbone, just below the nipple line, and give up to 5 chest thrusts. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the sequence of back slaps and chest thrusts until the object is expelled and the infant can breathe or becomes unresponsive. If the patient becomes unresponsive, place the infant on a firm, flat surface. Begin CPR with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the mouth wide. If you see an object, carefully remove it with your fingers. Don't stick your finger blindly in an infant's throat and attempt to sweep out an object. This can cause injury or push the object further down the throat, worsening the obstruction. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If the patient is pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the patient. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with the other hand and thrust straight backward. Try to not put pressure on the ribs. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the chest thrusts until the object is expelled and the patient can breathe or becomes unresponsive.
Hello po. You can take your lunch na po. See you again later po at exactly 1 o'clock p.m. for ACLS lecture po. Thank you po.
Okay. So let's settle everyone because we will have a rock and roll afternoon. Meaning we will work taking advanced cardiovascular life support is tough in terms of academics and quite a number of memorization. So I want you to catch up because we have two adversities. Number one, we are doing it virtually. Therefore, there will be lots of things that we can miss because virtual is not face-to-face. So yung maituturo ko, baka hindi niyo ma-imagine. Number two, I'm not requiring you because it's up to you. I'll treat you as adults. I require you to do your own simulation. After ACLS, gawa kayo kasi walang ibang way para maging magaling ka, kundi i-rerun mo yung mga natutunan mo. So it's like you have a walkthrough. Kahit wala kayong dami, nag-ano lang kayo, nagsisimulate around the bed. No? Not necessarily mag-CPR ka, nakaposition ka lang, tapos drug, epinephrine given, mga ganyan. Makukuha niyo na yan kasi ginagawa din namin. Actually, tomorrow morning, I'll be doing demo. At makikita nyo paano siya ginagawa. So welcome to the Advanced Cardiovascular Life Support Program, interfaced with Interim Guidelines of 2022, BLS and ACLS. Our format is from April 2020. Ito yung pinaka-latest, pero sinabakan ng 2022 Interim Guidelines. So yung Interim Guidelines, ano lang talaga, naka-focus para hindi kumalat yung COVID. Now, we will describe what ACLS, and we will revisit the chain of survival, yung basic life support, dinention ko, i-revisit natin ngayon. Then, of course, we have to understand pathological, yung mga tinatawag nating ACLS na ECG lang. Now, I'm not gonna teach you the whole ECG package of it. Mga axis, di ko na ituro yan. Yun lang mag-identify tayo ng mga pathological ECG na mag-i-intervene according to ACLS standards. Then we will have stations, airway station, cardioversion. Walang station yung cardioversion, ile-lecture ko lang. Transcutaneous spacing, tapos advanced airway. Ang advanced airway, i-demo ko yun. Then I will perform megacode. No? Mag-isa ako, kunwari may mga kasama lang ako. So mag-megacode para makita niyo paano ginagawa ang ACLS. So advanced cardiovascular life support is a word coined by the American Heart Association. Sa kanila talaga yan. At ginaya na lang ng ibang mga grupo, tapos binitawan na lang ng AHA na wala siyang intellectual property, wala. May mga bagay sa mundo out of control na, hindi mo na pwedeng habulin kung sino. Kaya ang nangyari, hinayaan na lang. But the unang gumamit ng word na ACLS is the American Heart Association. Yung ACLS is mainly algorithm yan, sets of rundowns for the treatment of cardiac arrest, stroke, acute coronary syndrome, ACS, acute coronary syndrome, other life-threatening cardiovascular emergencies. Isama natin yung mga how to intervene with arrhythmia, tachyarrhythmia, saka bradyarrhythmias. Pag tachyarrhythmia, ito yung mga atrial rhythms, tapos bradyarrhythmia, ito yung mga heart blocks. And it also covers pharmacology, ACLS pharmacology, electrical therapy. Pag sinabing electrical therapy, baka may PT dito. Isipin nyo yung mga electrical therapy sa PT. Dito, ang electrical therapy, tatlo. Defibrillation, cardioversion, transcutaneous pacing. And of course, paano ginagawa yung code blue? The ACLS is performed by doctors and nurses and even paramedics to intervene to a cardiovascular incident. And you are required to have training. Ito yun. Now, the scope is the 2020 protocol. Hindi ko na discuss. ECG reading, ACLS pharma, advanced airway. Hindi na ako magtuturo ng intravenous kasi alam niyo yan. Intraosseous na lang yung ipapakita ko sa inyo. Tapos yung defibrillator, paano ginagawa yung defibrillation. Tapos cardioversion, capnography, transcutaneous space. Lecture ko lang. Ang cardioversion, i-demo ko yung transcutaneous space. Wala kasi akong gamit pa. Meron akong transcutaneous space. Tapos megacode, paano ginagawa megacode. I will do lecture on ACS and CVA. Yung PULSE and NRP are separate courses yan. PULSE is Pediatric Advanced Life Support, saka NRP is Neonatal Resuscitation Program. Para siyang ACLS siya, pero intended for pedia yung PULSE. Neonate yung NRP. Then hypothermia management. So ACLS is the cornerstone of all ALS. Ibig sabihin, pag nag-advance ka, kahit saan ka mag-advance, lalanding ka talaga sa ACLS. Kasi lahat naman yan, kung anong mangyari sa'yo sa mundo, magka-cardiac arrest ka rin later on. Pag trauma ka, grabing trauma, magka-cardiac arrest ka. Pag intoxicated ka, magka-cardiac arrest ka. Mag-hypothermia ka, cardiac arrest. Meron kang metabolic imbalance like nasira kidney mo, meron kang hyperkalemia, magka-cardiac arrest ka. Whether you go into management, obstetric emergency, trauma, surgical, the end of the line is cardiac arrest. Therefore, ACLS is indeed the cornerstone of ALS courses. Yan. So ano yung mga core ACLS cases? Of course, yung respiratory emergency, 4 types of cardiac arrest, yung may mga rhythms ka na ventricular fibrillation, saka pulseless ventricular tachycardia. Then pulseless electrical activity, saka asystole. And yung pre-arrest, ibig sabihin, may arrhythmia ka, punta ka pala sa arrest. Ito yung bradycardia, na until you become unstable, tapos stable tachycardia na maging unstable, tapos unstable tachycardia, mag-arrest ka, and then acute coronary syndrome. And the last but not the least is stroke. So, ano ulit tayo? Daan ulit tayo ng chain of survival. Kanina, sinabi ko sa inyo, in hospital kayo, ang ACLS dito yan papasok. Ito. Pag nasa ambulance ka, dapat ang ambulance mo ay ACLS grade. So, pag after defibrillation, pag post-cardiac arrest care, yan yung ACLS. Dito, ang ACLS mag-start sa ambulance hanggang sa CCU. Same thing with pedia. Now, I want you to look at the slide kasi may mga, pag nagbasa kayo ng libro, when you open the book, if you have the book on ACLS, no? Lalo na itong 2020, merong ganito. Pag nag-mention siya ng intervention or drugs, lalagyan niya ng, tingnan niyo yung cursor ko, COR, Class of Recommendation, tapos Levels of Evidence. Ito yung Levels of Evidence. Ayan. Ito. Levels of Evidence. So, halimbawa, nag-mention ka, compression, lalagyan niya ng Class of Recommendation. Ibig sabihin ng compression, Class 1 yon. Tapos level of evidence, level A, high quality. Oxygen. Oxygen is class 1. Level level A pa rin. Level A or level BR. Epinephrine. Epinephrine is class 2A. Tapos level BR. Yung level BR, ibig sabihin, level B, randomize siya, moderate quality. May ibang book, ewan ko saan nila kinuha yun, Arizona yata, level A ang epinephrine. Anyway, depende naman sa study nila yan kung ano ang evidence, no? When you put a drug or an intervention into a case and how effective it is. So, ito yung ating ginagawa na evidence-based medicine. Along the way, lalo na pag nag-pharma tayo tomorrow, or mamaya kung kakayanin, pag nag-discuss na tayo, magugulat kayo, merong ganito, class of recommendation. Papakitaan ko kayo mamaya pag pharma na. I will not discuss abbreviations. Diretso ako dito sa ACLS. Just this morning, BLS tayo. So ito yung BLS na dinaanan nyo kanina. Kinulaps lang. Kinulaps lang siya. Okay. Because of the interim guidelines 2022, itong yellow, kinulayan ng yellow, in-explain bakit kinulayan ng yellow. Kasi meron siya, ito yung idinagdag. Dinagdag. Yung yellow na yan, yellow plate, yan yung how the program ended up into 2022 interim guideline. Emphasis dyan. Kasi yung 2020 update ng BLS sa ACLS, wala ganyan. Okay, so updated siya 2020, pero ito 2022 interim to. 2020, ang buong format na to, kasi baka malito kayo, ang buong algorithm is 2020. But the emphasis on PPE is what makes it the 2022 interim guideline. So, yan, ganyan ang laro dyan. Okay. Now, paano ang ano ang interplay? Okay, this is the interplay. Required na mag-doon ka sa PPE. In your hospital, hindi na siguro require ang level 4, level 3. Pag sinabing level 4, may face shield pa yan. Para kang astronaut, ayan, N95, gloves, kompleto. Wala nang ganyan. Pinakamataas siguro, level 3. Unless infectious yung hinawakan mo, sige, level 4. So meron tayong biolevels PPE donning sa Pilipinas. Okay. Now, dito sa Don PPE, level 3, level 4 to. So, wag tayong malito. Kung hindi niyo na sinusunod yan, hindi ibig sabihin, mali to. Ito ay ang utos ang utos ni 2024 pag saglit meron lang emergency for a while. Okay, sorry. So ngayon, meron na akong PPE, na-assess yung pasyente, naglagay ng oxygenation through bag valve mask, start ng CPR. Tandaan nyo, tingnan nyo ang laro dito. Prepare to intubate. Isipin nyo, nag-start pa lang ako ng CPR in an ideal setting, ni-ready na for intubation. So CPR ako. Kasi hindi naman, unless kung nasa ICU, wala sanang problema. Dito ako maglalaro sa general ward and ideal setting. Kung merong nakikinig sa akin dito na medyo sabihin natin, ang inyong work area is peripheral hospital at hindi nyo ma-comply ito, well, hindi ko ibig sabihin mali kayo. Kataon lang, ang medical practice talaga, if you want to attain the standards, no, mag-ISO ka, logistical nightmare talaga. Hindi ka pwedeng maging standard. Ang logistics mo ay laway-laway lang. Yan talaga yung hard fact in medical science. Parang ako, meron akong, tingnan niyo sa video ko. Tingin sa video. Yan, puro hard case. Mga drugs, burn unit, andyan yung ano. This one is ultrasound sa emergency. The future of stethoscope is ultrasound. So, pag nag-central line ako, ultrasound ang gamitin ko, tatalunin ko yung walang ultrasound. Tansya-tansya, mag-subclavian access, kung ano man. Or mag-pericardiosynthesis ako, mag-ultrasound. That's the point. Pag wala kayong gamit, at ang isang doktor may gamit, ang argument kasi natin is, magaling yung walang gamit. Pwede. Eh kung yung may gamit magaling din, talo ka. Pareho kayo magaling. Sa equal footing, pareho kayo magaling. Wala kang gamit, may gamit. Simple rule lang yan. Or stethoscope ka, yung isa may ultrasound. Tatalunin ka may ultrasound. Kung invasive ka masya. That's the point. Because medical science is dependent on logistics. Lalo na ngayon, nag-simulate ako ng emergency, I was there, no? Although disaster medicine. Isang hospital sa Israel, 2019, I was there, nag-retrain ako. No? Lahat ng kaso, halimbawa, kidney, about kidney. So nagkaroon ako ng problem sa kidney. Sabihin natin, CKD yung pasyente. Alam mo ang tao, dami siya. Ang kaaway ko, AI, Artificial Intelligence. Tatalunin talaga ako kasi AI yan eh. Bawat gagawin ko, hahanapan pa niya ako ng ano. Pupunuan niya yung kakulangan ko at ang mali ko, kinukorek niya ko. On the spot, kulang na dito. Dito, ganyan, kulang. May mga formularing gamot na hindi ko ginagamit sa Pilipinas. Ginagamit sa US o sa Israel. Ang Israel is independent so much. May mga gamot na ayaw nila, ginagamit ko, hindi nila ginagamit. So, to make the story short, talagang sasablay ako kasi AI ang kalaban. Na-address ko, buong ospital yan, AI lang. Ang pasyente mo, AI, except psychiatry. Kaya ang gagaling ng mga doktor sa Israel, kasi estudyante pa lang, dumadaan na sa ospital na yan. Sinasabak na sila sa kaso. Tapos ang kalaban mo, artificial intelligence. Grabe. Ang tindi. Eh di ka ba gagaling? Gagaling ka. Babalik ka lang. Kung nabobo ka doon, babalikan mo lang. So ang ginawa ko, balik-balik lang ako. Pero ang concentration ko is more on emergency lang talaga. Ayoko yung mga prolonged critical care. Hindi ako ganon. Hindi ako patient. Doon lang ako sa, lalo na trauma, doon talaga ako sa trauma. Wala gaano eh. Except yung nagra-rapid sequence intubation ako, maraming gamot, depende sa anong klaseng pagka, ano niya, ERSI ko. Other than that, sa trauma halos wala kang, ano eh, kung magbigay ka na ng, magbigay ka na ng, tawag nito, magbigay ka na ng mga, yung critical care, so state medicine, Yun yung ayaw ko. Hindi ako sanay na magbabantay ng pasyente sa mahaba. Gusto ko yung critical on the spot na yung ano, yung anyway, that's AI. So ngayon, balik tayo dito sa algorithm. Prepare to intubate. So tuloy na yung ano ko, tuloy na yung intervene ko, CPR. Andiyan na yung intubation. But biglang nakita ko ngayon sa machine, shockable rhythm. Nakita ko ventricular fibrillation saka or pulseless beta. Dati, nag-shock ako na. Boom, nag-shock ako. Pag-shock ako, after shock, CPR. Bago nag-COVID, pag nag-intubate ka, yung CPR tuloy-tuloy. Tandaan niya, hindi po nakaka-impede. Kasi nasubukan ko, nag-intubate ako habang nagsi-CPR, nakikita ko yung bula. Doon talaga yung lungs. So, ganoon mo lang ito, suction konti, pasok. So, walang problema, continue CPR, intubate. Nung nag-COVID na, bawal na. Una, bawal gumamit ng typical laryngoscope. Dapat ang laryngoscope mo ay merong video. So yun yung requirement ngayon. So hinto ang CPR kasi lilipad ang aerosol, tatanggal ka ng mask. Mag-intubate ka. Ang requirement sa intubation ngayon, kailangan magaling ka. Bakit? Ito ngayon ang ano. Inihingi ko yung ano ko. Kinukuha ko yung para bukas pag nag-intubate. Yung laryngoscope, hiniram sa akin eh. Pinapakuha ko. Bakit ganun ang requirement? Titignan natin at papalakihin ko. Gulo-gulo nito. Oops, sorry. Papalakihin ko itong slide. Transfer ko lang yung picture, video. Ayan. So makita nyo ngayon, dito, ayan, tingnan nyo. Minimize closed circuit disconnection. Anong ibig sabihin nun? Yung closed circuit disconnection, simula sa airway hanggang sa bag, close yon. As much as possible, huwag magkaroon ang air galing sa baga, lumabas sa environment. So, sarahan natin. So, it's either may mask or tubuhan mo yung tao. Ngayon, use intubator. Yung intubator dito, yun yung airway guy. Ang word na ginamit ko, airway guy. So, intubator tawag sa kanya. Ang intubator is the one who intubates with all the equipage. Use intubator with highest likelihood of first pass success. Ang first pass success, ladies and gentlemen, ay mag-intubate na dapat swak, hindi na magkamali. Okay? Yan ang requirement. So first pass success, yun yung what is expected of us. Okay? Next is consider video laryngoscopy. So ito yung in-emphasize ng tatlo sa interim guidelines of 2022. Kaya siya naka-bold. Okay? Kung magbigay ako ng exam, yan ang i-exam ko. No? Kasama ko yun. Okay. Siguro sa SPAS kayo. SPAS nagawa ko exam 100 mga multiple choice, mga ganyan multiple choice. Okay. Dito tayo nagkahiwalay sa mundo. Ako, meron akong laryngoscope, Macintosh, saka Miller, yung traditional. Okay, traditional yun. Meron akong video laryngoscope, tinex ko, pinapasauli ko kasi hindi niya sinasauli. Another, meron akong backup na sangkatutak na supraglottic, iba-ibang klase. King LT, Comtube, laryngeal mass airway, gel. Pakita ko bukas yung iba't ibang mga supraglottic na yan. Okay. Then, kailangan yung therapy attachment. Kasi nasanay tayo, natin yung popular fuel metabolism para ma-produce ang adenosine triphosphate, yung ATP, para may energy. Kaya ako nagkikilos, nagkakaway-kaway ako sa inyo. Nag-move ang muscle cells ko because gumagana yung nag-move ang muscle cells, nag-move ang muscles ko because yung mga cells sa muscle ko ay nag-aakto ngayon. So, gumagamit siya ngayon ng oxygen na 21%, gumagamit siya ng ng water, no? At yung glucose na kinain ko ngayon ay ginagamit. So, sa mitochondria, kasi oxidative process yan eh. It requires oxygen. Sorry. It requires oxygen. So, inside, merong oxidation of your pyruvate. No? So, saan galing si pyruvate? Diyan galing si glucose. Diyan ang naibibigay ni glucose. So, si glucose, or kung inom ka ng gatas, may lactose, no? Doon magaling si pyruvate. Tapos saan pa rin galing? Meron tayong yung tinatawag na kumain ako kanina, kita ko chicken skin kinain ko. So pwedeng fatty acids, tapos kumain ako ng itlog white kanina bago my lunch. So meron ako nakuhang amino acids para ma-harness ko yung mga bagay-bagay like electrons, no? Simple, meron tayong production na tinatawag nating carboxylation. The oxygen in metabolic in oxidative metabolism na po-produce si ATP nagre-result into the production of carbon dioxide. Tapos yung glucose ko in the form of calorie, and then ang water ko water pa rin, no? Yan lang yung hindi nagbabago, water pa rin. Hanggang nagpo-produce ng carbon dioxide, ang punto doon, buhay ang cell ko. So, ano yung capnometer? So, si capnometer ganito. Yung may pasyente lang ako saglit ha. Allergic reaction. Okay, grabe. Hanggang ngayon may pasyente, may consultation. Okay. Kapag ang tao ay mamamatay na, wala na siyang production ng carbon dioxide. So bakit napakaganda ng capnometry? Ganito yan. Nilalagay natin sa airway, siyempre pag nag-exhale ako, may carbon dioxide. Saan galing carbon dioxide? Kay blood. Saan galing kinuha ng blood? Sa mga tissues all over the body. So hakutin niya sa lungs, ilalabas niya. Inhale ulit ako ng 21% oxygen. Bakit 21? Anong law si 21? Sige nga, baka lang may makasagot. Total gas law. Sino? Anong physics yan? Kaninong ano yan? Parang walang makasagot. O sige, ako na lang. Dalton's law po yan. So, ang ini-inhale natin, umi-inhale tayo ng nitrogen plus carbon dioxide, oxygen, pero ang na-absorb lang sa katawan ay si oxygen, no? Kasi pag na-absorb si nitrogen, malaki ng problema. Okay? Nangyayari lang yan sa diving. Magkaroon ka ng DCI, decompression illness. Papasok sa tissue, tapos bigla kang umangat, from the tissue, si nitrogen hindi na ilabas sa blood vessel, magkakaroon ako ng mga air spaces. Anyway, that's totally different topic. Anyway, sa total gas, para lang ma-review kayo konti sa physics, because alam niyo, you have to love physics kasi physics is the answer to all the natural science sa mundo. So, meron tayong mga mixture of ideal gases, no? Yung total pressure, tapos yung sum of pressures of each gas, no? So, in the observation of that, nitrogen, oxygen, and other inert gases, yan si total gas law, si Dalton's law. So, paano natin sa equation sa physics yun? Letter P, which means the partial pressure, is equal to P1. Halimbawa, si P1 ko, nitrogen, plus P2, oxygen, plus P3, so on and so forth sa available gas. Ang total of it, sa 100 na yon, 21. So 100% na, 21 lang doon si oxygen. Yan. Tapos inhale ko si 21. Pag exhale ko, ilan ang oxygen? Meron pa rin. 16%. Aba, bakit nangyari yon? Kasi meron akong trachea, bronchi, bronchioles na walang exchange of gases. Ibig sabihin, walang passive diffusion to the blood. Kasi nangyayari lang sa alveolar area. Alveolus na paligiran ng blood vessel, no? At doon nagpapalitan. Other than that, walang palitan. So yung oxygen, pag in-exhale ko siya, mayroon pa ring amount of oxygen na 16%. Pero pag exhale ko, di ba makita niyo sa total ang capacity, meron kayong makitang tidal volume. Yun po yung tidal volume. Sa last part ng tidal volume, doon ang totoong carbon dioxide. Kasi yung unang buga ko, hindi siya carbon dioxide. Oxygen pa siya. Kaya meron akong 16% sa total na yun, sa tidal volume sa exhalation. I hope you understand. That's the grade 5 way I can explain it to you. So, pag minessure natin si carbon dioxide, yung machine, ang i-measure ng machine, the end tidal volume. Kaya, pag magbasa kayo ng libro, ang nakalagay is EtCO2, end tidal carbon dioxide. Bakit? Pag angat niyan, inhale, pag exhale ko, yung normal breathing lang. Unang buga ng exhalation, oxygen. Bakit? Merong anatomical dead space. So, naintindihan niyo anong anatomical dead space? Bigyan pa tayo ng parang board exam. Yung anatomical dead space, ay yun yung lugar na kung saan in the respiratory system, no? Kasi meron tayong tinatawag na physiological dead space. Yung anatomical or tinatawag na anatomic dead space, siya yung para siyang the volume na doon sa airway from the nose or sa mouth down to the terminal bronchiole. Yung bronchiole, no, ay hindi nakakapagkuha ng carbon dioxide kasi walang blood vessel. So galing sa nose, mainly nanghihinga ka sa nose, hanggang doon sa bronchiole, terminal bronchiole. Pagdating sa bronchiole, after that, yun na yung tawag nito, alveolar, bronchoalveolar, saka alveolar function. So, ay nako, daming problema. So, balik ako sa anatomical dead space. So, anatomic dead space, yan o. Hanggang bronchial, siguro mga around, ilang ml yan? Ilang ml ba? Average human, mga around 120, 150 ml lang yan. Inspired air, ang laman yan, at end of each inspiration. So, pag nag-inspire ako, tingnan nyo ako ha, pag nag-inspire, tingnan nyo sa video. Up to end of the inspiration and inspiratory, na trap dito oxygen, yan po yun, 150 cc yan. Oxygen yan. Pag buga ko, oxygen pa rin yan mainly. Until lalabas yung galing sa alveolus na kung saan ay carbon dioxide. So, ang minimeasure noon ay the end tidal carbon dioxide. I hope you understand what I'm pointing. So, balik ako dito. Post-chest compression, intubate ako. Tingnan nyo, wala pa akong IV. Tingnan nyo. So, ito hindi naman ibig sabihin na mahuli si IV. Pwede naman pagsabayin kasi ibang tao si intubator, iba din si IV. Pwede mong pagsabayin yan. Sinequence lang dito, ginigyan lang ng emphasis. Itong yellow, because itong yellow na plates ay siya yung bagong ano. Sorry. Okay. Tingnan nyo ang cursor ko. Intubate. Pumalpak. Sabihin natin, pumalpak ka. Pagpalpak noon, balik valve mask. Okay? Boom, boom, boom. Valve mask. Sorry. Balik tuloy CPR, valve mask, shock. After shock, intubate ka ulit. Pumalpak ka ulit. Ano nang gagawin? So ngayon, hindi ko po masagot yan. Ang makakasagot niyan kayo. Ano ba ang hospital protocol niyo bago kayo mag-supraglottic? Kasi may ibang hospital, pag pumalpak ka isa, supraglottic ka na. Kasi ina-achieve nga natin closed circuit assembly. So hindi ako makahintay. Pero kung sa inyo, meron kayong standing protocol, 2 failed intubation bago mag-supraglottic, yun ang problem. Okay? Ngayon, sa supraglottic, hindi na kailangan ng laryngoscope. Blind shoot lang yan. You can lock it and wala. Pero, hindi ibig sabihin supraglottic all the way. Kasi pag, assuming ang pasyente mapunta sa ICU, kailangan ko siyang i-mech vent, mechanical ventilator, kailangan pa rin talaga ay endotracheal. So, magre-reattempt pa rin talaga ng endotracheal. Ganun lang. So, when connect to ventilator with filter when possible. So, yun na pag na-connect na. Ang filter natin, kasi yung in-exhale ng pasyente, kailangan nasasalo yun para yung COVID ay hindi kumalat sa loob mismo ng ICU. So dito ngayon sa itong rundown natin sa ACLS. Shockable rhythm, ang mangyayari dito, shock, bigay ka ng epinephrine, drugs, shock, bigay ka ng epinephrine or amiodarone or lidocaine. So depende. Incidentally, asystole. Pag sa asystole ka, bilisan mo talaga ang intubation. Okay? Yan. Okay? So, tingnan nyo ang cursor ko. Pag shockable rhythm, maganda, shock ka, naka-IV ka, pwede ka na magbigay ng drugs. Kasi usually sa assembly ng Pilipinas, yung airway, hinihintay si anesthesiologist. Gano'n naman kahit sa gobyerno. So si anesthesiologist takes time kasi kung sa ER ka ngayon, bababa pa siya ng ER. Kung sa ward, bababa pa siya. So hindi ka agad ma-intubate despite the fact na sabi ng AHA i-intubate. So mauuna most likely si fluid. Okay? Pagdating sa asystole, dito mas kailangan i-mandatory talaga natin. Bilisan, no? Yung CPR, no, after kailangan na intubate. Nakita mo asystole. So order for CPR. Nag-start ka ng CPR, na-cover na ako ng 2 minutes. Tapos prepare na for intubation kasi nakita ko sa screen flatline ako. Bago tayo mag-declare ng flatline, people, kasi ang ating default lead is lead number 2. Alam niyo yan? Lead number 2. Bakit lead number 2? Okay? Sa lead number 2, kita mo flatline. Pindutin mo yung pindutin mo yung nakalagay sa machine, papakita ko yun bukas. Nakalagay doon lead, L-E-A-D. Pag pindot mo sa lead, lilipat sa 3, lead 3, flatline. Pag pindot mo, lilipat sa paddle sign. Eh kung naka-paddles ka, pinatong mo ganun, flatline. Pero wala, shortcutin mo lang si paddle sign, pindot isa, lipat ka sa lead number 1, Roman numeral 1, flatline. Pindot isa, balik ka sa Roman numeral 2, flatline. Saka ka mag-declare ng flatline. Huwag ka mag-declare ng asystole na tumingin ka lang sa lead number 2. Baka sira ang lead mo. Kunwari lang, sira si lead number 2. So i-check mo lahat ng leads bago mag-declare ng flatline. So dito ngayon, chinek ko. Uy, asystole, number 3, flatline. 1, flatline, balik sa 2, flatline. Okay, people, we have flatline, CPR. Please prepare intubation. So, CPR, may nagbigay na ng line, intubate ka agad. Success. After 2 minutes, pagbigay ng line, epinephrine ka kagad. Bilisan mo yung epinephrine kasi ang trabaho ng epinephrine is to coarsen the rhythm. Rhythm check after 2 minutes. Pagtingin mo, flatline pa rin. Continue CPR. Bigay ka ulit ng epinephrine. Okay? Pero naka-intubate na ako. Pag oras naka-intubate ka na, wala, asynchronous na yung compression ventilation. So nagko-compress ka, tuloy-tuloy na siya. Tapos yung ventilation every 6 counts, every 6 seconds. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. Ventilate. 1,000, 2,000, 3,000, 4,000. Ventilate. Okay? So yan ang mangyari. Until flatline, sinettle mo yung reversible injuries, reversible factors. Ito yung reversible factor. Palakihin. Ito tingnan nyo cursor ko. Reversible. Halimbawa, hypovolemia, hypothermia, na-settle yan. Tapos yung capnometry ko ay nasa 10 to 12 or below 10. Wala na pag-asa yan. Halimbawa, CPR ako. Pasok na ako ng 20 minutes. Na-settle lahat itong reversible factor. Intubated ang pasyente, lahat na-settle. Pero ang capnometry ko ay 10. Diyan ka mag-declare to stop CPR. Diyan mo i-declare on the cellular level, the patient is dead. Hindi ba pwedeng sa mata, constriction? Case-to-case basis. What if ang patient ay head trauma? Paano reliable yung mata mo? Oh, hindi. Head trauma yan eh. So, hindi reliable. Okay? What if the patient has glaucoma or the patient meron siyang lahat tumitingin sa ECG. Luma pong tugtugin ng ECG to determine the patient. Lumang tugtugin yan. Meron tayong probable sign of death. Flatline yan. Kahit naka-flatline yan, it is not yet a definitive death. Okay? It is still a probable death until proven otherwise. Pag umakyat ka sa korte, pag marunong ang lawyer, paano mo dineclare ang pasyenteng patay? Sabihin mo, may flatline sa ECG. Pag marunong ang lawyer, tapos ka ngayon. Do you know capnometry? Pag sinabi mo, wala po kaming capnometry, wala na tayong magawa. Pero kung ang lawyer ay, tapos isang nasa ospital ka na sikat, hindi pwede yon. Hindi siya acceptable. Because before you declare the patient is dead, ang magsasabi ay capnometry. Ngayon, susunod tayo sa American Heart Association 2015. Simula 2015, even 2012, sinunod na yan eh. Pero naka-take off 2015. Pag in the absence of a protocol, si lawyer nagbasa ng AMAHA 2015. Naalaman niya ito palang capnometry. Lilikuin kanya doon. Wala tayong standing law. Pero meron tayong tinatawag na scientific evidence, which is the capnometry. Matatalo tayo doon. Tandaan niya na, matatalo tayo doon. Wala namang patakaran sa Pilipinas, you declare dead. ECG, hindi na yata yan eh. Sa manual natin, ang pinakabago, kung susunod ka talaga sa standard, you declare the patient is dead when the capnometry reading is 10. Doon sa probable sign of death. Kasi merong definitive sign, halimbawa, putol ang ulo, syempre dead na yon. Or merong signs of lividity, yun na yung definitive. Pero pag umabot ka sa probable sign of death, pwede ka lang magsabing patay na yan kung ang capnometry mo ay 10 below or 12 below. Hindi flatline ng ECG. Hindi mata-mata. Dilated na pong pupil. Eh kung meron niyang ininom na drugs na na can dilate the pupil, tapos intoxicated siya. Oh, so ano yun? Ano yung drugs na can dilate the pupil? Anyone? Hindi na. Nag-drug dilated yan eh. Tapos trauma pa. So, halimbawa, mga stimulants, dilator yan. Mga psychotropic drugs. Okay? Alam niyo yung marijuana, nakaka-dilate yan. Amphetamine, nakaka-dilate. Okay? Ecstasy, nakaka-dilate. Okay? Your alcohol even can dilate your pupils. Pero nagliliit. Dilate siya. Dilate siya ngayon. Haluan na lang natin, trauma na dilate pa. Merong na doon. Hindi siya reliable. Therefore, the most reliable is your capnometry. Okay. So yan, pinalaki ko lang. Yan ang mangyayari, yan ang ating ACLS setup. So sa CPR natin, push hard, push fast, adequate recoil, yun yung sinabi ko sa BLS. Tapos pag nagbigay ng shock, ang pinaka-common ngayon is biphasic. Okay? Ang ceiling joules is 200. Meron pang gumagamit ngayon ng monophasic, ang ceiling dose is 360. Okay, meron pang gumagamit. Pero pinakamaganda biphasic kasi mas hindi siya harmful sa heart. Tapos, yun, advanced airway, na-discuss ko kanina. Tapos, ang drugs natin initially, epinephrine, 1 mg. Wala na po tayong mga binibilang na dilution na 1:10,000. Ideally, yung emergency drugs na epi is 1:10,000. Ngayon, hindi na. Ang dati, pag 1:1,000, binibigay natin sa anaphylactic shock. Pag 1:10,000, binibigay natin sa cardiac arrest. Ngayon, hindi na natin tinitingnan. Binibigay na natin si epinephrine every 3 to 5 minutes. Amiodarone, 300 milligrams, bolus, ang second 300 milligrams, ang second dose is 150. Lidocaine is 1 to 1.5 milligram per kilogram. So, ang standard na binibigay is 100 milligrams. Ngayon, then we look at the reversible H's and T's. No? Pag-uusapan natin yan pagdating ko sa drugs. Yung mga hypovolemia, yung hypoxia, hydrogen ion or deacidosis, hypokalemia, hyperkalemia, tapos hypothermia, tension pneumothorax, tamponade, toxins, tablets, thrombosis pulmonary, thrombosis coronary. Ito ngayon yung interim guidelines for ACLS. So kanina nabanggit ko itong itaas, bababa ako dito. If intubation delayed, consider supraglottic. So dito lahat, advanced cardiovascular na to. Before intubation, use bag mask device with HEPA filter. Yung gagamitin kong bag mask, BMV or BVM, wala pong HEPA filter. Imagine na lang natin merong HEPA filter. Okay, para lang masaya. No? Kasi luma siya. Pag nagkataon, bibili ako ng merong HEPA filter for the sake of sa academics lang. Tapos, itong minimize closed circuit disconnections. Ibig sabihin, kung anong nakakabit sa pasyente, huwag sige tanggal. Okay. Tapos, hindi ko nabasahin to, no? Kasi ito yung luma na ACLS protocol. Yan, mga luma yan. Pinakita ko lang sa inyo how it evolved along the way. So, ano ba ang gagawin natin kapag nag-arrest? Babalik ulit ako. Consider natin yung CPR quality. Yan. Ito yung 2020 guidelines. Push hard, push fast. Okay? 100 to 120 and allow complete chest recoil. So, 2 inches daw. Hindi mo naman ma-measure yan. Para malaman nyo, 2 inches, kahit flat tummy yan, ang kanyang tiyan ay flat. Tatalbog ang tiyan pag good compress. Minimize interruption in compression. Tapos avoid excessive ventilation. Ngayon, sa drug therapy, epinephrine natin, intravenous or intraosseous, 1 mg per ml. Amiodarone is 300 initial, second dose is 150. Lidocaine is 100 mg. Pag nag-advance airway tayo, endotracheal tube, depende, 1 failed bago supraglottic. Baliktad sa amin, kami supraglottic kami. Pero meron akong ET. Pero dahil field ako, mas gumagamit ako ng supraglottic. Okay? Then, pag nag-return to spontaneous circulation, i-check ang BP sa pulse ox, kung okay ba, kaya ba. Pag hindi pa ang hemodynamics, magbigay ako ng mga pressure drugs. Okay? Para gumanda ang sirkulasyon. Tapos, i-monitor ko yung end tidal carbon dioxide pressure. It should be more than 25 para mag-indicate na maganda. Pag greater than 40, ibig sabihin, buhay na yung tao. Then sa shock energy, again, biphasic, 200 joules max. Pag monophasic, 360 max. Now, let's go into tachyarrhythmia. Sa tachyarrhythmia, tumaas ang rate ng pasyente, heart rate per minute. Lampas ng 150. Usually, mga starting ito 180. Ano ba ito? Supraventricular tachycardia, SVT, or atrial fibrillation with rapid ventricular response, or atrial flutter with RVR, rapid ventricular response. Huwag mo siyang iwan ng ganun kasi maya-maya mag-a-arrest yan. Kasi tandaan nyo, ang heart, sumisipa lang ng dugo yan. Hindi yan nagsasipon ng dugo. Hindi yan umihigop. Sa sigisipa niyan, wala na siyang makukuha ang dugo pabalik. Okay? Ngayon, anong mangyari? Pumasok ang pasyente or yung pasyente sa ward ay nakitaan mo na sa cardiac monitor ay gano'n. Okay, saglit. May tumatawag lang sa akin. Balik agad ako. Saglit lang, saglit. Sorry for the interruption. So dumating ang pasyente o nasa ward ninyo, tapos nakita nyo sa monitor, mabilis ang tibok ng puso. So mataas, around 200, 180, 200. Delikado yan. Kasi mapapagod yung heart. So paano natin titingnan? So, siyempre, we have to intervene. One, kabit sa cardiac monitor, lagyan natin ng oxygen, kuha ng blood pressure, and then we will check what's happening. Tandaan nyo lang to, itong blue, HASIA. Is there hypotension? Ibig sabihin, less than 90 systolic. And or, is there altered mental status? Biglang, hello? Nako, ito, ACLS yun. SBT. Pinag-usapan rin SBT. Problema SBT. So, sinabihan ko anong gagawin. Okay. Walang alas 5. Tawag doon. Okay. Is there hypotension and or is there altered mental status and or signs of shock and or ischemic chest discomfort and or acute heart failure? Pag merong yes, kandidato siya for electrical therapy, ang tawag synchronized cardioversion. Ituturo ko paano kayo mag-synchronize cardioversion if you haven't tried it. Okay? So tuturo paano. Ngayon, kung hindi naman present itong nasa blue plate, no, tignan natin kung ang QRS is wide. So, kailan wide ang QRS? Paglampas sa 12 of a second. Tatlong small squares. Okay? IV access ka kaagad, 12 lead ECG. Tapos, bigay tayo ng adenosine 6 mg. Tapos, pwedeng kung hindi kaya si adenosine, sa 12, gusto mong mag-verapamil, okay lang din. Gusto mong mag-beta blocker as long as ang BP ayos. So, depende. Marami tayong anti-arrhythmic. Kapag stable ang pasyente. Pag unstable, cardioversion. Until, pag white QRS siya, no? White QRS, yes. Adenosine pa rin, pwede ako magbigay ng amiodarone. Pero pag narrow QRS, pwede ako mag-start ng vagal maneuver. Ang vagal maneuver ay minamassage. Pero bago ka mag-massage, i-check mo muna na walang carotid bruit. Kasi pag may carotid bruit, it's an indicator na ang pasyente ay merong aneurysm. So, adenosine pa rin. So, ang adenosine is the first drug of all, wide man yan or narrow. Kung wala kang adenosine, pwede ka magbigay ng verapamil. Sorry, sa wide pala, sa yes, hindi, huwag ka mag-verapamil. Sa narrow, maganda ang verapamil. You can also use beta blocker. So, sa tachyarrhythmia, ganito lang ang assembly. Yes, no ka lang. Presence of ASIA, hypotension, and or altered mental status, and or signs of shock, and or ischemic chest discomfort, and acute heart failure. Okay? Or, pag no, tingnan natin kung wide versus narrow QRS. What if, yan ang mga gamot. So, sa cardioversion, in case talaga i-cardiovert natin, presence ng ASEA, pero ano yung rhythm mo? Narrow regular, katulad ng SBT, you can start at 50 to 100 joules. No? Ang pasyente dito ay pinatulog natin. Ako, ang experience ko, kaya ng midazolam. Pero kung gusto mong medyo malakas, etomidate, fentanyl, yan, malakas yun. No? Kung gusto nyo magbigay ng ganon. Wala akong preference masabi sa inyo kasi doctor's preference yan. Happy na ako sa midazolam. Hindi nga lang matagal. Hindi naman matagal mag-cardiovert. Minsan, nakadalawang fire ako, ayos na eh. Nami-maintain na rin ng gamot, kaya na ng gamot. Pag narrow irregular, halimbawa, atrial fibrillation with rapid ventricular response, pwede ka ng 120 to 200 joules by phasic. Okay? Kapag wide regular, you can fire at 100 joules. Kapag wide irregular, wide na irregular pa, katulad ng torsade du poids, ay defibrillate ka na, hindi na pwede cardioverse. Yung adenosine, ito yung pinaka magandang gamot pero medyo nakakatakot. Bakit? Mahal. Pangalawa, hindi mahaba ang shelf life. Okay? Hindi mahaba ang shelf life. Pangatlo, pag ibigay mo, kailangan mabilis. Pwede mo lang siyang ibigay kapag ang swero mo ay nandito. Pero pag nakatibia ka, nakatibia intraosseous, medyo mahirap dahil ang adenosine, mabilis siyang patayin ng red blood cell. Yan ang problema sa adenosine. No? Mahal na, mag-effective siya. No? Ang nakakapatay sa kanya, pag delay mo siyang binigay, nagbigay ka, no? Nagbigay ka na ng ano, meron kasi tayong tinatawag na yung pagdating sa blood, merong yung adenosine triphosphate, no? Metabolism in red blood cells, no? Kasi parang ganun yung ano, pag na-mix siya sa blood, mabilis siyang ma-destroy ng blood. Okay. Kasi part siya eh, na si adenosine kasi marami siyang nagagawa. No? It's a regulator ng mga biological function. So nagre-react din siya, hindi lang siya sa heart nagre-react din siya sa blood. Kaya short-lived lang siya. Kasi pag binigay mo si adenosine, kukunin siya ng red blood cell. Ang adenosine, ang gusto ko mag-action siya doon sa blood, sa heart. Binigay ko, mabagal siya sa RBC. Within 3 seconds, kuha siya. Kasi ang kumakain ng adenosine ay si endothelial cells, si myocardial cells, at saka si RBC. Isipin mo ang kaaway ng heart mo, endothelial saka si RBC. Kailangan mo siya ibigay mabilisan, tapos tulak agad 20 cc NSS. Kaya pag nagbigay ka ng adenosine, kailangan may 3-way stop ka, hindi yung pwedeng bigay ka tapos bunot, suksukan mo ng 20 cc NSS, patay na si adenosine mo. Ang nangyari, pag patay na siya, mahal na, wala siyang epekto. So para gusto mong makita ka magandang epekto, tulak sa adenosine, tulak agad si 20 cc NSS. Yan lang yung ayaw ko kay adenosine. Okay? Tandaan nyo, di ba? Nabanggit ko kanina. Saglit lang. Hospital to hospital. Okay. Pag nag-second dose ka, 2 ng vials. So 12 na siya. Pwede ka magbigay ng ibang gamot katulad ng procainamide, pero ang procainamide is third level to. Third. So there was in my life, sa lahat ng practice ko, nakadalawang gamit lang ako ng procainamide. Maganda siya, no? So nag-start ako, nagbigay ako ng 20 mg per minute. Na-suppress ko yung na-suppress ko yung rapid ventricular response. Amiodarone, okay ang amiodarone sa akin, lalo na kapag mga wide TACI, wide complex. Okay, amiodarone 150. Then sotalol, pwede siya pang-maintain. No, sotalol 100 mg or 1.5 mg per kilo over 5 minutes. Okay. Amiodarone 150 mg over 10 minutes. Si sotalol mo, basta bantayan mo lang, huwag lang bumagsak yung BP. Yan lang ayaw ko dyan sa sotalol. Pero mabilis din siya mag-block ng tachyarrhythmia. Now let's go into bradyarrhythmia. Dito naman sobrang bagal. So dati pag bradycardia, maraming kaso. Meron tayong pump failure, no, distribution failure, mga ganun. Ngayon hindi na. Tingnan lang natin, hasiya ulit. Anong klaseng bradycardia? Katulad ng makikita nating bradycardia pag-usapan dito ay dulot ng karamihan dyan, heart block. Okay? Heart block. So pag may heart block ka, lalo na pag second degree type 2 at saka complete heart block, yan yung big problem. Magbabrady arrhythmia. So anong gawin natin? Makakita ka, less than 50. So, hook to oxygen again, vital signs monitor. Okay. Maintain airway. Okay, and then 12 lead ECG, IV access, alamin kung merong hasiya ulit, hypotension and or altered mental status and or signs of shock and or ischemic chest discomfort and or acute heart failure. So, ganun lang natin siya abangan. Okay, saglit. Okay. Sorry. So, sa bradycardia, makikita natin kung present yan, yes, or kung hindi present muna, monitor lang. Basta wag lang mag-unstable yung aking pulse ox. at huwag ako mag-hypo. Yan ang usual presentation. Pero merong indicator, may isa dito sa 5 na to. Bigay ako ng atropine. First dose, 1 milligram. Repeat every 3 to 5 minutes. Back up ko, dopamine. Very conservative, dopamine ka. So ito yung ginagawa ko kasi nakaka-treat akong ganito. Pero there was one time, ipit talaga ako, 40, pangit talaga, nag-transcutaneous spacing ako. Ito. Transcutaneous spacing. Okay? Now, DOPA, pwede ka rin magbigay ng epi as infusion, 2 to 10 microgram. Pero I'm not happy with epi. DOPA pa rin ako. So, pag nag-transcutaneous spacing ako, hindi ibig sabihin, hindi ko itutuloy si DOPA. Naka-dopamine ako pag transcutaneous space kasi pagbigay ko ng midazolam or diazepam, tulugin ko yan. Hindi tatagal, mamaya nagigising, nasasakta na siya doon sa transcutaneous. I will explain transcutaneous spacing to you pagdating sa electrical therapy. Ito naman, pag return to spontaneous circulation, no? Anong gagawin natin? So, depende yan sa klase na heart. So, nag-return to spontaneous circulation. Pero mahira ang hemodynamics. Pwede natin i-hypotension, less than 90, mahina ang hemodynamics. Pwede ako mag-fluid challenge, bigay ako ng mga vasopressor, pwede pa rin ako mag-dopa. Pero kung sa tingin ko, dahil ang pinakasimula, bakit siya nag-arrest dahil may STEMI, kailangan ang objective ko, maano pa rin siya. Pwede ko siyang mapa-stent or ma-PCI. No? Lalo na pag STEMI is present, ayan. Kasi baka kaya siya nag-arrest because of cardiogenic shock. Nako, baka pwede ako mag-NOR-E. No? Paano natin malaman na meron na siyang heart rate pero pangit pa? Tingnan nyo ang saturation. Meron na akong heart rate pero yung pag ang inotropic configuration ko mababa pa rin. Hindi pa rin nakakasipa ng dugo. So makikita ko siya sa pulse oximetry. And then, kung naka-intubate pa, hindi ko binitawan, tingnan ko ang waveform capnography. Pag mababa siya, ibig sabihin hindi pa siya fully okay. So, susuportaan ko pa rin. Kahit naka-return of spontaneous circulation. So, ang mga gamot, ito, halimbawa, to maintain ventilation oxygenation, alalayan ko, 10 breaths per minute, bubugahan ko pa rin. When feasible, titrate FiO2 to minimum necessary to achieve 92 to 90. Pwede ako mag 2 liters, 1 liter normal saline or LR. Ito, hindi ito ginagawa kasi naging 2B siya. Itong tinatawag na induced hypothermia, yung 4 degrees centigrade, NSS, ibigay mo sa katawan ng tao para siyang pinapakoma mo siya. Pero actually, lalo na sa stroke, maganda daw to. Hindi ko pa to nagawa, pero maraming disputed pa siya. May nagsabi 2B, may nagsabi 3 sa class of recommendation. Pwede ako mag-dopamine from 5. Dati kasi ang 5 is tinatawag nilang cardiac dose. Pag 5 to 10, tinatawag na renal dose ang 5. 1 to 5 renal dose. 5 to 10 cardiac dose. 10 to 20 is vasopressor dose. So sa atin, tinatitrate lang natin. So depende ano ang display ng pasyente, 5 to 20 microgram per kilogram per minute. Pag may cardiogenic shock, pwede tayo mag 0.1 to 0.5 microgram ng NOR-E. Okay? So hanapin natin ang reversible causes at the same time. Kung gusto niyo mag-epinephrine infusion, okay lang. But I'm not comfortable with epi infusion. Hindi ako fan. Na-try ko once, ayoko na siyang ulitin. Pero hindi maganda yung outcome na nangyari. It might not be epinephrine, pero parang yun lang, parang ayoko lang siya. Hindi ko siya feel. Sa stroke, okay, balik ulit ako sa Cincinnati Pre-Hospital Care. Anong gagawin natin? So sa stroke, ito yung goal. Sa ambulance pa lang, ito na talo ng Pilipinas, no? Ambulance pa lang to, ha? Ito. Itong cursor ko. ang ambulance sa Pilipinas, bihira ka makakita ng advanced life support. Number 1, nasa ambulance pa lang, pinick up mo sa bahay, check mo glucose, perform Cincinnati pre-hospital care, tapos give oxygen, triage to, tawag ka na sa stroke unit, stroke center sa hospital. Ang problema, wala tayong ganon. No? Ilan lang. PGH, yung talagang may stroke. Dating doon sa ER, tingnan nyo, ito na side. Within 10 minutes, dapat nasa ER. Pagdating, within 10 minutes na perform lahat. Grabe, no? Tindi. Kaya ba? 10 minutes ang ER. Grabe. Diyan pa lang, talo ng Pilipinas, hindi kaya. Okay. Now, bakit ito? Kasi yung tinatawag natin stroke admission program. Kung sa heart, itong Dr. Nidal din. So, bakit natin pinabilisan? Dahil i-detect natin siya for CT scan. So, CT scan, ano ang resulta? 20 minutes to 40